Good morning and welcome to Bradford Health Services' third CU event for our 2024 series. I'm Sherry Shaper. I am the Corporate Director of Clinical Operations at Bradford Health Services, and I will be introducing today's session and offering technical support. I want to thank everyone for joining us today. Bradford will be hosting one final contact hour or contact event for this year, and our events are posted on our website. We'll post a link for those in the chat box, so you will have that for future reference. Before I introduce today's session, I want to share some important information with you. You're viewing this in webinar format, which means that you can see the presenters, but your video and your audio are off. Please use either the chat or the Q&A functions located on the bottom of your screen to ask questions or communicate with our panelists or attendees. I see several of y'all have already started that. At the end of the presentations, we will have a panel discussion where questions received will be answered at that time. Please note that you will receive a post-session email including a link to materials presented today, including the PowerPoint presentation, as well as a link to the video recording of today's presentation. Today's session is eligible for 3 hours of continuing education contact hours. Bradford Health Services is providing continuing education contact hours at no cost to you. In the post-session email, you will also receive a link to an evaluation. You must complete the evaluation in order to receive credit for your participation for the CEUs. Certificates will be sent via email to those who complete the evaluation within 2 weeks after you complete the survey. We were expecting a high attendance for today's session, so please be patient in waiting for those CEUs to come to your email. We have one staff member that processes those evaluations and certificates. We will also be posting that survey link near the end of the presentation in the chat box if you would like to go ahead and do it today, so you don't have to worry about remembering it afterwards. Finally, if we experience any technical difficulties today, please stand by while we do our best to resolve them. If we get disconnected, we will resume the webinar as quickly as possible. Now that we have the housekeeping issues out of the way, let me introduce our session. We are excited for today's session on the opioid crisis and treatment strategies. We have 3 excellent presenters today who are all very knowledgeable in this topic. They will share information on the opioid epidemic and treatment strategies, including medication interventions, by providing unique perspectives from their own areas of expertise. I'm going to briefly introduce our speakers at this time, but they're going to provide more specific information regarding their backgrounds during their presentations. Our first presenter is Zach Ludwig. Zach serves as the Vice President of Clinical Services and Accreditation at Bradford. Our second presenter is Dr. Brett Ballew. Brett serves as our Director of Pharmacy at our Warrior Inpatient Facility in Warrior, Alabama. And our third presenter is Jennifer Dunkin. Jennifer serves as our Assistant Director of Nursing at our Warrior Inpatient Facility, also in Warrior, Alabama. All 3 presenters will be available after the presentation to answer questions, and I hope you enjoy the presentation. I'm now going to turn it over to Zach.
Good morning. Thank you, Sherry. Welcome, everyone. As of this moment, we have about 550 of you joining us from all over. Thanks for checking in on the chat. As Sherry said, not necessary for us recording your attendance, but we appreciate lots of activity in the chat. I see a lot of people checking in, telling us where you're joining us from in the different regions. You know, as we're watching the weather overnight, there was a great deal of trepidation on my part about our ability to move forward and if we'd have any disruptions. So as Sherry said, hopefully we have no connection issues, knocking on some wood. And wherever you're joining us from, hope you are safe and secure. So we have a full agenda for today. We're going to be covering a broad topic, but focusing on it from a couple of different perspectives. I get the pleasure of starting out first and speaking about some of the background of our opioid crisis and giving you some up-to-date information there. This is a topic that we've been covering pretty consistently really since we started this series in 2020. And I like to be able to provide you the updated information, what's happening out in our client population, and then giving you some macro information about trends and things like that. As Sherry said, my title is Vice President of Clinical Services and Accreditation for Bradford. I've been with the organization for 13 years. I'm a licensed counselor in Alabama, Tennessee, and Florida. I started out working at the organization in Tennessee, and since 2016, I've moved to Birmingham, Alabama, where I work out of our corporate location, working with our clinical operations across the entire organization and monitoring our effectiveness to meet the standards of our respective state departments of mental health, as well as accrediting bodies such as the Joint Commission and CARF. So I'm going to be speaking a lot of today, as I said, from some trends areas, but also talking about some of the challenges that we're facing. Really a lot of this early presentation is going to be very much embedded in the problem, and then my idea is that we'll move into the solution together as we hear from our other speakers today. So, with no further ado, here's some very latest trend data that's available, and you can look this up on various sources. I like to use the CDC, SAMHSA, as well as the Kaiser Family Foundation for updated data. If you're ever looking for good sources, I endorse those. So we don't yet have 2024 data. That'll come next year, of course. But for 2023, this is what we were shown by SAMHSA. And this data you're seeing on your screen is the number of people who have used an illicit substance in the last year. So this is not someone who is classified as having a substance use disorder. We'll get into that a little bit more in a minute. But what some takeaways from this slide are, and you may not be surprised, marijuana is the most commonly abused illicit drug in the United States. We're seeing trends where there's initiations of use earlier on in age groups, and even some folks who might be a little bit older who are initiating the substance for the first time. And there's a lot that's propelling that with legalization of recreational use and a general destigmatization around marijuana and its use. So those rates remain very, very high, as you can imagine. Hallucinogens, that's things like psilocybin, magic mushrooms, LSD, and so the trend rates there are actually increasing. I'll give some more context of that in a minute. For some of our main focus for today is going to be around opioids. So this will include prescription pain reliever misuse, which is classified here as about 8.6 million people in the last year misused this medication. Followed by cocaine, prescription tranquilizer, and sedatives. So when I'm talking about sedatives, I'm usually talking benzodiazepines, Xanax, Klonopin, Valium. Followed by stimulant misuse. Stimulant, in this case, prescription stimulant misuse is things like Adderall, over the counter, often ADHD or ADD medications. Followed by methamphetamine. While this presentation is going to focus in on opioids, I will have some commentary about stimulants and methamphetamine because there is a connection here with our overdose epidemic we're in. And then inhalants, and then heroin. And heroin is sometimes surprises people. It is a very, very low rate. And that's something we're seeing in kind of the modern era of opioid use because heroin is not as accessible on the street. It is either just not available or more expensive than alternatives such as fentanyl or other analogs. And so that rate has actually stayed fairly stable. What you see more is if people are using it, they're also adulterating it with other opioids or nitazenes, which we'll talk about. So overall, when you compare to just a couple of years ago, we do see some increases in the amount of use, and it is in certain categories over others. This describes that in a little bit more detail. So just compared to the previous year's data, 2022, marijuana is slightly down. That's a slight. But as I said, we're also seeing certain age groups that are more likely to adopt that use. Hallucinogens up slightly. That's been a bit of an ongoing trend. Prescription stimulant use was slightly down. Inhalants was slightly up, and you also do tend to see that more among young people. Methamphetamine down more than half. That was a pretty significant year-over-year reduction. But I'm going to give you some data later on in my portion, talking about the explosion we really had in the last 5, 6, 7 years, really, with methamphetamine use. And some of this was just pre-pandemic and carried us into the pandemic, and was kind of additive with some of our overdose rates that we were seeing at that time. Prescription sedatives, again, benzos, is up more than 100,000, and I'll also speak to some of the reasons behind that. And heroin down by 2/3. Again, access and just kind of changes of trends in the market. This is past year substance use disorder for those age 12 and over. So this is a diagnosable condition. And the first two lines on the right side diagram are going to show alcohol use disorder, which is the most prevalent reason why someone enters into a residential treatment center. It is still alcohol. Despite a lot of the discussions we're talking about with opioids, and there's certainly a great deal of patients who are entering treatment because of opioid use disorder, but alcohol is still one of the main drivers nationwide. And then they give you the drug use disorder, which really lumps in all of the numbers underneath that. So again, marijuana being the leader there, followed by the prescription pain reliever misuse, methamphetamine, prescription stimulants, cocaine, and then lastly, heroin. What this diagram tells us is that about 17%, based on these numbers, if you add up 48 million and 235 million, it gives you a number. It's a little bit lower than if you look at current, if you Googled what is the US population, it's not going to be that numbers, because part of this is it's a couple of years old in the data, and it's also based on sampling. So, but getting in the nitty gritty aside, we're talking about 15 to 17% of our United States population having a diagnosable substance use disorder to some degree. And that could be mild, moderate to severe in terms of diagnostic criteria. But again, that's not an insignificant portion of our population. And that's why I'm so happy to have all of you joining in, because I know of all 615 of you currently in this session, substance use disorder is not necessarily your primary focus. But I'm telling you, you're having these folks walking into your private practice or your clinic or whatever your setting is. If you're focused in on, you're the couples counselor, you're the marriage and family therapist, seeking to understand the couple's relationship with substances might go a long way in helping to pull back some layers as to what might be going on. That's just a little tip. We must do better in our assessments across the board. That's first soapbox over the day. Here's a diagram of substance use prevalence. It's the same numbers I just showed you, breaking down the alcohol and the drug dependence, but this shows you that middle ground where someone might be struggling with both conditions. So about 7.5 million people with an alcohol use disorder also had a drug use disorder, and that's about 15% of those with substance use disorder. Co-occurring presentations, that's co-occurring with other mental health conditions, but also just co-occurring substances is not uncommon at all for someone seeking treatment. Certainly there are people who enter treatment and they only drink alcohol, or they only use fill in the blank other substance. But especially when we're talking about drug use disorder, the either trading one for the other or seeking out alternatives as a means of necessity many times is not very uncommon. Some good news. I said I'm going to talk a lot about the problem, but I do have some positive things to say. Our overdose death rates nationwide do seem to be plateauing and or potentially decreasing a little bit over the last year, really. So the provisional data from the CDC estimates that more than 100,000 people died of a drug overdose in 2023. Saying a six-figure number has not been all that uncommon for a number of years. But what's interesting is that is a approximate 3% reduction from the death rate we saw in 2022. A first annual decrease in drug overdose rates since 2018. And that's really when a lot of attention in terms of our presentation was really focusing in on the significant increase rate. Nevertheless, more than 1 million people have died since the turn of the century from drug-related overdoses. And here shows a little bit more nuanced breakdown just year over year of some of the types of substances. So the synthetic opioids, the fentanyl, what you actually see there is a bit of a decrease, which is the first time that number has decreased since I have been doing presentations on this topic. I attribute that greatly to prevention programs and increased education in our world about fentanyl and efforts by organizations to talk about medications, as someone is saying in the chat. MAT is making a difference. Amen to that, Sarah. Psychostimulants up. And again, I'm going to talk about it because we can't leave that out of the discussion here, as cocaine is also up. So also going to talk about that. And so the natural or semi-synthetic, so that'd be your heroin as well as your prescription pain medications, also seeing reduction. Goes along with what I've already said about heroin, but also the prescriptions are down because of efforts with prescription drug monitoring programs and efforts to reduce doctor shopping and abilities to fill in exorbitant amount of medications with unlimited refills and all of those things that have become problematic in our time. So here's the death rate really since turn of the century, and you see that synthetic opioids really have been our primary driver really since 2013. And this is driven by fentanyl. And another chart that shows this, and this is going to be our kickoff to go a little bit deeper into some of the antecedents to the crisis. These show you the waves of the the modern opioid crisis we are in, really starting around 1999 with the rise of prescription medications, and then shifting more to heroin, and then, as I've said, moving away from heroin to more of these synthetics. But let's go a little bit deeper. The first wave, really attributed 1999, talking about OxyContin and Purdue Pharma and other big pharma companies, big pharmaceutical companies that were selling opioid medications as quote unquote safe and non-addictive, using marketing tactics, going directly to doctors in aggressive manners. And what can best be said for physicians at the time is that they were either susceptible to the gimmicks or to a worser degree complicit in the prescribing explosion and seeing within their communities the damages being done. I highly recommend the miniseries that I have a picture of on the screen here. It's called Dope Sick. It's on Hulu. Has Michael Keaton in it. It is a wonderful representation of different facets of addiction, from the marketing side, from the prescribing side, from the end user side, and the progression of that dependence. It really is a really powerful series, and I recommend it to all, and even recommend using aspects of it in our treatment settings to spur on some discussions about what we're seeing on the screen. Simultaneously, around this time, there was a lot of things going on in our healthcare system, including the Joint Commission adding the fifth vital sign, that's in quotes, which brings pain management more to the forefront, which then simultaneously brought along the question of, well, if you're not adequately addressing this person's pain, could you be found to be, malfeasance, malpractice type situation where you're not providing the standard of care as it was defined at that moment? Problem with pain is that it can be incredibly subjective. It can be very difficult to have a true monitor on whether interventions are proving effective. And there was a great deal of fear among physicians who were being sued because the patients were saying, "You're not addressing my pain," or you're not taking care of me. And what that created was the tendency to just prescribe in order to address what was right in front of you, while simultaneously that same system generating exponentially across our states and settings, where these quote unquote pill mills were originating, where basically it was where people could go. They knew they could get easy access to large amounts of opioids, refills available, Then they could go across town, do the same thing in another physician, another urgent care, and would continue that trend either for personal use or for selling on the street. Um, Opioid prescribing became a major focus for a lot of our prevention efforts for a very, very long time. And while things do show improvement, we in Alabama in particular, that's where I'm sitting, seeing a reduction just over the last couple of years, that's continuing a general overall trend of 38 to probably now closer to 50% reduction since around 2011. But the important thing here is that America still consumes more drugs, period, but especially prescription drugs than any other country in the world, which means we are prescribed more medications and drugs than any other country in the world. And there's a lot of reasons for that. And I'll have some more information on that in a couple of slides. But when we look at that and you put that next to our figures around mental illness, substance use disorder, overall general health, suicide rate, just general these quote unquote diseases of despair, you wonder if there has to be something more than correlation here. But I'll leave that to others to debate. So prescription medications, big problem. Then we start cutting debt back on that. We start policing that better through various programs, prescription drug monitoring programs, also called controlled substance monitoring databases. This all really starts to crack down on these pill mills. Well, here's the thing. If you cut down on supply while not also addressing demand, you only create a black market. And that has been proven time and time again. This is called the iron law of prohibition, coined in the 1980s. But look at that in our history with drugs and alcohol in this world. Alcohol prohibition did not work. All it did was move things underground, made things more dangerous, making bathtub gin and make you go blind. When you remove someone's access to comparably safe, and I'm using that as a very quote unquote, a pill acquired at a pharmacy, you know what's in it, you know what potency it is safer comparatively than buying something off the street or go seeking heroin, which is exactly what happened. Seeking out low-cost heroin that had a supply chain often driven by illegal activities in cartels and other criminal enterprises, there was a demand in the market, and they filled it. And what we know about what happened with a lot of people is that they would be transitioning from their prescription dependence to heroin because they were going through withdrawals. Because without having that drug, that medication, they were incredibly sick. It is a big misnomer in general society that substance users, especially opioid users, are trying to get high with every one of their uses. Might have been how it started. It might have been some early feelings of chasing that initial euphoria. Feels like a warm blanket that wraps around you, and you feel safe and content for the first time in your life, and forever you're chasing that because it's never quite the same. But more than anything, once that progresses, you are using so you don't feel like total crap. And because it's the worst flu you've ever had, body cramps, diarrhea, sweats, your heart's racing, your head's pounding. I mean, on and on. I mean, there's so many other symptoms. It's a just, I got to kick this can down the line so that I don't feel terrible and I can function at a baseline. And that's how people transition over to heroin. And then as you can see, then some of these folks progressing into seeking out using injecting heroin due to increased tolerance and needing at that point a drug supply that was a bit weaker in order to get to the potency they had been accustomed to, using more and more and using in more direct manners to get over that blood-brain barrier as fast as possible. Heroin comes in a lot of different forms. I'm not going to go too much into the differences, but it looks white, it looks brown. what the white, can be a little bit deceiving sometimes because, it could look like other substances too, and especially it gets cut with other things, lactose, sugars, things like that. Black tar heroin is actually pretty sticky. Tend to do more of the melting down for that for the IV use. But you can IV any of these with the powders. You tend to see a lot of intranasal ingestion, or putting it on another drug, maybe marijuana or even tobacco, and smoking it. Okay, so heroin hits the scene, big problem, still problem, lesser problem, but still there. Third wave, because cartels are smart, and let's not let's not pretend that they're not. This is an enterprise that is making billions and billions of dollars, and is doing this illegally. So they're doing things sometimes even in a more difficult fashion than our corporate America. Cartels said, we got to be moving product. And it's a lot easier to move something discreetly that's smaller than something that's big. So thinking about, your prototypical drug distribution system where we're moving kilos of a substance, cocaine, heroin. You've seen the movies. These are big bricks of 1,000 kilograms of a powder, right? It's not small. Well, fentanyl and other analogs provide a really ingenious alternative in that we can have a very small amount that is as potent as the equivalent that takes up a lot more space. We can move it into the country, then we can either sell it directly as a very potent opioid, or we can start mixing this in with other substances, adulterants, and cut it, and then increase our amount, and then hey, profits will rise. So that's basically how that worked. It's no more complicated than that. And so on the screen, I'm showing for you what's considered a toxic or a lethal dose of heroin. And this would be for a non-user, someone who's opioid naive. That's someone who does not have a tolerance. You have heroin on the left, then fentanyl, similar amount of what could potentially kill you, and then carfentanil. Very, very potent. 10,000 times more potent than morphine is what carfentanil is. And just a little speck, a little grain of salt or sand is all it takes. Now, why fentanyl is and what it is? I mean, it's a medication. It's a drug that's been around. It is around. It's an FDA approved medication for pain relief and an anesthetic. There are people who need fentanyl in their day in order to function. I think about people with very severe, terminal, life-ending illnesses that might be receiving aid through things like fentanyl patches, which, by the way, the World Health Organization identifies as the safest way to administer fentanyl is through these dermal patches. It is incredibly potent. So it's not intended for the person out walking around, and really it's not being prescribed for that person out walking around. It's being prescribed in very specific settings. It is potentially lethal because of how strong it is. Now, again, somebody who has a tolerance built up over time may not have that exact experience. It's an opioid, so its euphoric effects look like morphine, looks like heroin, looks like hydro. But depending on amount and potency, might be more pronounced. Again, as I said, often laced in with heroin or other drugs. They are pretty easily produced if you know chemistry, and there's plenty of criminal labs out there, clandestine labs, who would be more than willing to fill in the supply gaps. This goes over a little bit about some of the presentation you would see. As I said, works pretty much this way for all opioids. A relaxation effect, euphoria, pain relieving, sedation, can present with some confusion, drowsiness. It's kind of that nod that it kind of goes characteristically with opioid use. Potentially nausea, vomiting, pupillary restriction, pinpoint pupils. That's one of the kind of easy from across the room might notice. And then the respiratory depression, and that's the really dangerous part. So that's this part that as you're breathing and your heart rate go down, that's where things get scary. And we're going to get a pharmacist perspective on some of the reasons why that happens here in a second. So what we see with overdose is, this stupor. It's almost like a Walking Dead, zombified, just very rigid in the presentation, clammy skin, kind of that goose flesh um, skin you see, respiratory depression again, as I noticed. Um, the coma, the pinpoint pupils, and the respiratory depression, that's going to really be an indication of opioid intoxication. And we're going to talk about options that exist later on today. But one of our best things we have to fight this right now is Narcan, which I encourage you to have. This lives in my backpack everywhere I go, because it's not going to be the person who's going to use Narcan. It's going to be a bystander walking by who is able to intervene. And I want to, I'm not going to, I don't try to step on too many of Jennifer's points for later, but a recent OSU study that just came out, they surveyed 1,000 Americans, and like 78% said they do not feel equipped to know what to do if they saw someone who was overdosing from opioids. So despite a lot of our efforts, despite prevention programs and education, I see billboards when I go down the highway talking about how to get Narcan. That's excellent. We still have education gaps to fill. So let's keep doing the work. All right. So I was just talking about fentanyl. Its uglier cousin is carfentanil. Wildanil is the other name, and this is an analog of it. It's even higher potency than fentanyl. It's dosed out in micrograms. It's mainly used in veterinary medicine, like if you wanted to do anesthesia or analgesic on an elephant. That's what you would use. These are just substances, y'all. These are just chemistry. They exist in the world, like it or not. It's what happens when introduced into a person or a population that is is this a problem? Is this something that we must be addressed? Because there's so many substances that exist for which we don't deal with the societal ires compared to things like opioids and other drugs. There's a whole bunch of chemistry out there that exists that is positive for society and a good thing. These substances can be good when used in the right hands. If I had a terminal illness and I needed a fentanyl patch because of very, very severe end of life pain, I would like that to be available to me. However, we have to find the balance in our world about how these things exist and how we interact with them. So since really the last couple of years, we've been seeing a bit of a comeback, is what has kind of been said about seeing this high degree of potency in the world. Hey, Melissa, I see your comment there. That's a good comment. I'm going to get there. I like that a lot. That's a good note that you just put in the comment. Keep them coming, guys. I can watch the chat as I go. So carfentanil was especially prolific just before the pandemic, kind of went away a little bit, and then we saw a little bit more of a spike. I want to speak about rainbow fentanyl. Just a quick commentary. This is a little bit about what was just chatted at us, is that there's a lot of misinformation that does get put out there in the media. And one of the examples that I was most struck by was around August 2020, when there were all these news stories going around about rainbow fentanyl, and the DEA, and this is still on their website, they say this is an effort to target kids and young people. I have a little bit of a dubious response to that, because I know that there are young people and adolescents who are using opioids. I know that because we're treating some of them. But we're also seeing more of an overdose rate among the people in their later teens, 20s, and especially 30s. If the street level was going to try to target kids who are generally opioid naive, we would have even more dead kids. And that's not really what's happening. What the colors are and the stamping that you put on a pressed pill, that's just street level marketing. That's just people saying, hey, I want the red ones, I want the blue ones, you got the Nike swoop ones. Because like you see a lot in the MDMA and rave culture, there might not be a lot of difference between the substance that's in the pill or in the powder, but it's more about creating somebody who will go to this dealer versus that because they have the cool looking ones or whatever. So something to think about there. Here's another think about it. And I think it's just an interesting because I like to find interesting things in the data. The correlation, this is certainly probably not causation, but correlation between opioid deaths and antihistamines. So 18% of the, at that time, around 92,000 drug overdose rates that we had in 2019 to 2020 involved antihistamines, most often Benadryl. So Benadryl is, there's a lot of things to be said about Benadryl. That's for another discussion. But Benadryl in and of itself is relatively safe um, because only about 90 deaths total per year can be attributed solely to Benadryl. But we have to wonder if the additive effect of having antihistamines on board, which might be creating some respiratory depression, plus the ingestion of opioids, is going to result in an increased likelihood of overdose and death. Yes, questions coming in. Yes, I will elaborate on the comments that being made. Yeah, stay with me for a couple more slides. Somebody asked, were they adding Benadryl to the street drugs to hide the potency? That's a potential theory. The research I read on that particular slide didn't mention that. It seemed to be more it was on board as just it came out in the toxicology, kind of inferring that was they had taken Benadryl and then at some point thereafter taken opioids or some vice versa. But that's an interesting point, especially as we get into this topic now about other adulterants, most notably on our scene right now, xylazine, also called Xylamed. We're seeing heroin, fentanyl, and pretty much a lot of other opioid analogs being cut with this. This is said to increase or extend, not necessarily increase, but extend those euphoric effects that someone is seeing. Because this is not an opioid, it's not responsive to Narcan. This is not a controlled substance. It's a veterinary medicine. It's been around since the 60s when it was created by Bayer. They did some human studies on it. And then they found, hey, this creates severe hypotension, so reduction in that blood pressure. And the CNS depressants, it's too dangerous for humans. So that's why it's we're not really talking about this as something being diverted from medicine. This is just a substance that exists out there. But again, you can find a lab that'll sell it to you. Where there's a will, there's a way, and you have the resources. And a lot of these are coming out of Chinese suppliers for about $6 to $20 per kilogram. On the street level, the slang name for this is usually trank or tranquilizer. I'm not going to read a lot of this slide. What I am demonstrating here is each one of these represents kind of a different resource or different study that talked about the increase we saw from different periods and for different regions. Definitely seeing a big increase in areas that are often very hard hit from substance use disorder, Baltimore, Philadelphia, areas like that where the overdose rate and heroin and other opioids are not uncommon in their communities. And big takeaway here is increasing. We are finding it in our drug supply. That's the. Someone says they're a reversal agent for this medication. No, there's not, because it's not an opioid. So if it's on board with you, and usually again being cut with other opioids, the Narcan might be addressing the opioids, but not necessarily this. You still should administer the Narcan. Don't try to investigate what is this exactly. Administer the Narcan, even if you're wrong, no harm, no foul. You could just move on to the next strategy. So some states have talked about adding this to their list of controlled substances, which would result in some tighter regulation. And while others are considering focusing more on penalties and punishment for those that they find in either distribution or possession situations of the drug. Comes back to the question, to the idea of, does prohibition and punishment work? Some advocates, specifically talking about xylazine, worry that creating the additional punishment, the additional stigmatization might increase isolation. You will drive people away to more back alleys, to using on their own, and that's where people die. If we can focus more on expanding access, treatment services, prevention, strategies like drug checking, which I'll elaborate more on in a minute, and a pipe dream, wow, it would be wonderful. Safe injection sites, needle exchange programs, and places where people can use their drug of choice without feeling that they're going to be arrested, so that if they are having a medical condition, we can keep them alive. Wow, wouldn't that be a wonderful thing to see in our society? The supply chain will shift to wherever the demand is, and punishment does not work, period. So, where could this go if we crack down more on xylazine, which we already are? But where are we already in some ways? These Frankenstein, to use the word that I've actually pulled right out of the literature, these nitazines. So, a lot of these, coming from middle of last century, they're trying to find new opioids. Because remember, this is business, big pharma. What new meds can we bring onto the scene that treat pain better, that don't cause bad side effects, yada, 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 right? So there's a big push, especially post World War II. There's some reasons for this. That's a bit of another history topic we can do another time. But right after World War II, we had a lot of scientists who had done research during the war to various degrees, and propelling into pharmaceutical industry new options. Finding that a number of these were too toxic resulted in too much danger for human use. So, classified, once classification came around in the 70s, classified as Schedule 1. However, where there's a chemist, there's a way, and there's still certainly unregulated labs, especially in China, that are increasing production. And we're seeing this circulating more and more in the United States. It's cheaper to produce than illicit fentanyl and heroin, and it's usually stronger. And again, it goes back to moving things in higher strength. It creates an efficiency in the supply chain. I really like the comment I see here. I want to go ahead and talk about that. It's a phone line that our participant Ashley has shared called Never Use Again. This is a phone line. It's a good harm reduction model where someone who is intending to use their drug wherever they are, home, apartment, wherever they are, they call in, they talk to the person, they usually ask for some basic information. What's your name? Where are you? What are you doing? Just so I'm aware. And they talk them through, okay, now you're using, and then they'll check in every few seconds, every few minutes. Hey, how are you doing? And if they don't get responses, then that triggers them to alert 911 EMTs to come to your location to help you. This is something that can be considered again as harm reduction. It is a resource because people are going to use. Period. We want them to stay alive. Staying alive is your best option for being able to seek a life in recovery, because if you're dead, you can't get there. All right, so here's some key concerns with fentanyl. Small amount can be deadly. Talked about that. You cannot always tell with certainty if a drug has fentanyl in it. So there are some methodologies out there, such as what's called drug checking. So drug checking, the idea is that if you had a pill or a powder, you take a bit of it, you put it in like a bottle cap or some other reservoir, you put some water in it, you take a fentanyl drug test strip, similar to what you'd use if you were testing urine to see if there was fentanyl in it. You dip it in the water and drug substance, and if it came back positive, that gives you a pretty good indication there's fentanyl in it. So now the user is an informed user, and they get a chance to make decisions. Is this okay? If I am going to use this, I will use it potentially a smaller amount than I originally was planning. I will make sure that there's someone around me. I will make sure that person around me has Narcan. Like there are strategies that make some sense here. Here's the problem: you can't necessarily always get a great sample just out there on the street without using mass spectrometers and other kinds of devices. You shave off a little bit of a pill. How do you know that side of the pill didn't have, it was the part of the pill that happened to not have any fentanyl in it? It's kind of like a chocolate chip cookie, and all the chocolate chips end up on one side of the cookie versus another. And so that might inadvertently create a false sense of security. So now the person thinks, oh, this thing doesn't have any fentanyl in it. And they take the whole thing, and oh, that whole other side was nothing but fentanyl. So it can lull you into a false sense of security sometimes, which might then create danger, and you might overdose because you misjudged it. With fentanyl, because of the high potency and affinity it has for the neurotransmitters, sometimes naloxone may not be entirely effective. Or if it is effective, effective only for a short amount of time before the person reverts back into the intoxication and overdose state. Or you might need so much to overcome the affinity on those receptors that you don't have enough around. If you're only carrying a couple of these with you, you might exhaust these, and unless you have emergency services immediately on the way, who can bring in additional supply, you might still lose the person. I will say there is a demand on the street level for fentanyl, which is continuing to drive supply. And a few years ago, it was fentanyl is scary, and I saw somebody put that in the chat, so I'm kind of quoting that. Fentanyl is scary. I saw someone say it. It is, and a few years ago, it was, to me, especially scary because of how much of an increase overdose around people being ill-informed about it we were seeing. The thing is now, there is people who are more informed about it, and there's a driver to seeking out pure fentanyl, because then at least you know what you're getting. Because there's so much adulteration of our drug supply right now that you can't use anything with any assurance. And that's going to spill over into our next conversations here about how this just one pill can kill campaign. Because we know that there's all these counterfeit pills hitting the market where it looks like something else. So it might be that it looks like a Xanax, it looks like a Hydro. Meanwhile, it is all fentanyl or some combination, and without doing some drug checking or really being rigorous around what you're about to take, there's significant risk, and this is again big driver of what was causing the overdoses. Now, I've been using, and I will likely continue to use, the word overdose, and I've talked about that as the experience that we're focused on for this presentation. There is an idea of shifting some of this discussion, rather than using the word overdose, talking about poisoning as a more accurate representation of the physiological response to that lethal substance. Saying something like death due to fentanyl poisoning is becoming, or toxicity, is becoming much more of the norm in how we report these things. And it has relevance around especially this inadvertent exposure. So let's say somebody uses cocaine. They intend to use cocaine. They sought out cocaine. Hey, I'm going to do a line of cocaine, and they died. Sometimes we would historically say they died of an opioid overdose. Well, that makes it look like they had sought out opioids. But in this case, what it was is they were exposed to a toxic or poisonous level of an opioid. Overdose has a stigmatization of bringing in that whole thing about choice again. They're choosing to take too much, or they were choosing to use the opioids and then they had too much dose. That's a basic definition of an overdose, right? But because that's not necessarily the real story, and especially with all these inadvertent exposures, we have to do better about classifying these things. And we already know that there's a lot of holes in the data, because you rarely know, or there are only specific circumstances where you know that someone, let's say, intentionally overtook an opioid with the intention of dying by suicide. You'd rule that as a suicide, right? Well, a lot of times that number gets put into the opioid overdose numbers, because that's what was the mechanism for their death. Unless there's some circumstance that gives some pretty good evidence of it was an intentional poisoning, it can often be misclassified. So our suicide rate numbers are going up, our overdose rates are going up, and there's some kind of overlap in these where we don't quite know which category it best should be. Texas, Ohio, and Illinois are potentially looking at some legislation around some of this language. I think it's a good move. We are now already in the fourth wave of the modern opioid crisis. And this really started a couple years before COVID and has really continued. So we saw big spikes in methamphetamine use and seeing reports of it being interlaced with heroin and other opioids. There is no overdose medication for stimulants at this time. So I told you that methamphetamine has been coming down a bit, but telling the story of the last few years, we're seeing number of people who continue to seek out cocaine. We're seeing an increase in first-time initiates of cocaine use. Some of this is being driven by what I'm seeing in some just cultural things, where more songs seem to be referencing it more than what was happening a few years ago. So I think young adults and adolescents are experimenting with it more. With amphetamine, we know that there's this is prescription amphetamine. We know that there's a dearth of supply of Adderall and other things out there. And I'm going to give you some data on that here in just a second. And again, you think you're getting Adderall, but it's fentanyl, and that's really the danger. You cannot trust the supply. Methamphetamine use rates, coming down a little bit, but overall high. Trying to look at the constellation of stimulant use is complicated because so many of them go hand in hand. You're talking with someone who's using methamphetamine, but they might supplement it with prescription amphetamines or cocaine if that's accessible, or MDMA because pretty much, and that's Molly or ecstasy, but it's really methamphetamine in a different outfit. It's really so much of it is driven by methamphetamine as its main component. So trying to kind of weave through like what kind of amphetamines or stimulants, I should say, someone's using, it's a lot harder than some other drugs. But one of the things that's fueling some of our recent issues around amphetamines really started during COVID. So this is a resource I pulled that came out July of last year. Is talking about Cerebral, which was an organization that was kind of an upstart doing telehealth. And they were doing targeted ads on social media. And a lot of this can be based on your browsing history. So think about what you were browsing during COVID. You were browsing like I'm feeling depressed. What are people doing to lift their spirits during this time? And it's saying, oh, are you struggling to get out of bed? Oh, is your attention sometimes misfocused? Is it hard for you to remember things? Maybe you have ADD based on the endless hours you've spent scrolling through Instagram and TikTok over the last 24 hours. We will give you a targeted ad that says, we will do a telehealth appointment, give you a basic questionnaire, and say, you have ADD. So in 2022, telehealth prescriptions accounted for 40% of all Adderall prescriptions. Part of what fueled this was basically a ceasing of the constraints around the 2008 Riot Hate Act, which put rules around being able to ship interstate and international any medications, especially controlled substances. But because of people needing access to legitimate medications, that was lessened in terms of restrictions during COVID. AI, artificial intelligence, is a big driver around a lot of this because what it's able to do is focus targeted ads on that viewer. As was said a few years ago from a doctor I have quoted here, it says the prescription amphetamine crisis is growing and could catch up to the opioid epidemic in scope and damage. That's very interesting to watch. This is one of those citizens of the world things to be aware of, especially in our world where we are one of two countries where we allow direct-to-consumer marketing of prescription drugs. It's us and New Zealand, interestingly enough. Talked about meth a little bit already. Increasing pre-COVID, drastic rates, 180% increase from 2015 to 2019. It's not affecting every community exactly the same, especially seeing in communities of color and in more urban areas higher rates of death due to the stimulant use, but especially then it being adulterated with the fentanyl and the other synthetic opioids. We were seeing a lot of damage being done. And one of the quotes that I pulled from that time that I'll share with you is the nation's focus on the opioid crisis, with its devastating impact on white rural communities, distracted attention and resources away from the deadly spread of methamphetamines in communities of color. I think that's a very, very relevant statement, because we're seeing these psychostimulant rates going up. So at the top, you see cocaine, and at the bottom, you see psychostimulants, primarily methamphetamine is how they classify that. So seeing an increase in the little yellow line, that is the stimulants mixed with fentanyl, pretty much. And so that is a big driver of what's causing those overdose rates, because you see, like, the stimulant by itself, while it certainly can be deadly, is not the main driving force around these. This again talks a little bit about what we were seeing a couple of years ago around amphetamine in particular. And the reason I still hold this slide here is the message that I have, that our overdose efforts must focus really on all drugs. If you have somebody presenting in front of you, or a peer or whoever it is, and they're thinking that this can't touch them because they're only using fill in the blank, they're only using cocaine, they're only using yada yada yada, we can't trust it. Our supply again is not trustworthy more than probably ever before in our history. And one of the areas, again, to be mindful of is with benzodiazepines. So again, we have a lot of people, 12% of Americans take benzodiazepines. The majority of them do not misuse them. The majority of them do not meet criteria for a sedative or hypnotic use disorder, but it's out there. And what we know about benzos in particular is that they tend to be shared a lot among peers and especially family members. Mom has a prescription, and oh, daughter, you're having a lot of anxiety, take one of my Xanax, they help. And that's how things kind of start. Well, now you've introduced this as a precedent. So now what happens when that person might seek out a Xanax on the street level, not knowing, hey, it's not actually Xanax. And I say street level, you might be picturing like them going out to the back alleys and trying to find this from dealers. Picture it at the college party. Think about it at the event, the concert. Who knows what it is? That's how you're getting exposed to these things, and it's based on bad intel, bad information, and a toxic drug supply. We are seeing that benzos and opioids can go hand in hand in terms of the overdose death rates, because again, the additive nature of this being a respiratory depression, which has some very important ramifications when we talk about prescribing. Someone who's on opioids, very, very careful with, are they also on a benzodiazepine? Because they both result in the sedation. And 2016 study found that overdose death rates among patients receiving both types of medications was 10 times higher than those only receiving opioids. So CMS has recommendations around prescribing guidelines. This needs to be considered with our MOUD / MAT providers and OTP providers, because it's not uncommon that I interact with a patient who maybe has been on buprenorphine or even methadone, and they're telling me about their experience, usually at one of these OTP clinics, and finding through their history that they were also co-prescribed benzodiazepine. Now, certainly there will be times where people will be taking them, illicitly off the street and things like that, but the concurrence I see of it being prescribed, sometimes by the same prescriber even, causes me a great deal of concern. So for I'm getting kind of to the end of my section a little bit, but I'll have an opportunity to talk more later as we get into some questions and answers towards the end of our overall presentation. To shift the gear a little bit, though, I want to talk about some kind of other synthetic opioids, but they're also, I'm going to call them kind of opioid adjacent. So there's a lot of things that kind of hit our scenes in different times in different ways. I mentioned the nitazenes that have been part of pharmaceutical exploration since the 50s. I've talked about a shifting of more potency for things that have already existed in our world. Fentanyl was not created in the opioid epidemic. It already existed. What we got was clandestine labs that would create it and create an illicit supply chain. There's other things out there though. So like a couple here I have U47700, which sounds like a World War II submarine to me. Also called pink heroin, pinky because of the color the powder can take on. This was a designer drug synthesized in the 70s. You started to see a little bit more reemergence around it, especially in the club scene around 2016. We have some past legislation around this that put it in kind of an emergency scheduled status. W18, been around since the 80s. How did it get put on the scene? Well, at some point, there was a pharmaceutical company trying to come up with an analgesic option, and they synthesized this thing. Well, it starts being used a little bit more in the designer drug culture. And then in 2015, seeing an increase of seizures of this kind of drug in places like Canada and in our adjacent border area than the North United States. I will say, there was a lot of exaggeration around some of it. It wasn't as big as the news media was making out to be, but hey, that's the way news media is. They make a story, right? Kratom, again, it's not really an opioid, but it can produce opioid as well as stimulant-like effects. So you may be really familiar with this substance because you might have seen signs, especially like head shops, herbal supplement shops, things like that sell this. Or a lot of times people are buying this online. Um, it is an herbal substance. It is found in a tree. Like many things that exist in our world, they started from natural sources. Opiates, as an example, starting with the poppy cultivation and then being synthesized into opioids, the synthetic. But in this case, this comes from a plant in Southeast Asia. And in that part of the world, utilization of this as a pain relieving option, help with mental health symptoms, anxiety, things like that, helping to even curb opioid use, which in other parts of the world is less of a pronounced problem, though still a significant societal concern. But it's like a replacement. It's like this is looked at more of as the MAT of for opioid solutions. That's a natural, as in occurring in nature, substance. In the United States, in particular, we've had a pretty mixed regulatory response to this particular substance, and it continues to be mixed. Some jurisdictions have certainly banned this; you can't buy it. I will tell you, it's not hard to get, as is a lot of things, but this one's even easier to get for general. Compared to Tiana, which harder to get, but still really out there. Increased prevalence in the few years leading up to COVID. It was kind of a big focus there for a little while, right before COVID set in. Called Zaza, Tiana Red, a few other different things. Marketed as a supplement, again, in many Asian, European, and Latin American countries, actually something that you can buy legitimately because it's seen to assist with anxiety and depression. Structurally, it seems to be similar to tricyclic antidepressants, as well as working off of the mu and delta opioid receptors, which creates that agonist effect, as in activating effect. You'll learn more about receptors here in just a minute. So it does have it's doing something similar to what you might get with opioids. I will say one of the things in that, just to look at that from kind of a 30,000 foot view, tricyclic antidepressants are one of the a pharmaceutical that certainly has a lot of utility in our world, but they have to be very much monitored, because just stopping something like a tricyclic antidepressant can cause a great deal of harm. And that's, I think, one of the main drivers behind some of the issues we've had with Tiana, is that the withdrawals from it would be very pronounced, and we were seeing dangers, including overdoses and deaths because of that. 2019 to 2020, increase in poison control and ED calls went up significantly. In early 2021, actually, the state of Alabama became the second state to ban Tiana sales, and they classified it as a Schedule II. And allegedly, you can no longer purchase it over the counter at convenience stores and gas stations and all the wonderful places you were seeing this stuff existing before. Um, so that's our modern opioid crisis in a very brief nutshell. And I realize a lot of this is data and kind of the problem. So what I want to do now for a lot of our remaining time, we're going to move more into the solution here. We're going to start that out. I'm going to turn over to Brett Ballew. I'll let him do his primary introduction, but he's a director of pharmacy at our Warrior, Alabama campus. Warrior, Alabama is located just about 20, 30 minutes north of Birmingham, Alabama, if you're not from around here. We have a residential site there. It is one of our operating residential sites that we have that spans 6 states now. I just want to highlight that. Bradford operates in Alabama, Mississippi, Tennessee, Florida, Texas, and North Carolina. We can provide you more information on that towards the end of the presentation. In the meantime, I'm going to turn over to Brett for a little while, and I will see you back shortly, but enjoy his session. Thank you.
Thank you, Zach. Zach did a good job covering the modern opiate crisis and kind of what we're going through now. And I'm going to cover a little more on how opiates work and kind of why we see the problems we do of patients seeking out opiates. So one of the main things, or to introduce myself first, I'm a licensed pharmacist in Alabama, Tennessee, and Mississippi. I'm also a licensed consultant pharmacist in Alabama and Mississippi, and a licensed preceptor in Alabama. I collaborate with Stanford University on several things, but most recently it was a development of an OUD certificate for their third-year pharmacy students. I have been with Bradford since 2013, and I have experience in both retail pharmacy and addiction medicine. Something I didn't include on here, I am our consultant pharmacist for one of our Mississippi sites as well. So just kind of a brief overview, and kind of what we'll cover here is neurotransmitters and the receptors involved in addiction. So there's some key players we have to think about in the brain. One of the key players is the dopamine system, and it's activated by rewarding stimulus. So there's several different key players in different parts of the brain that are involved. You've got the medial forebrain bundle. It has ascending and descending pathways, and it connects different areas of the brain that are also involved in the opiate response and what we see when patients take opiates. The ventral tegmental area, that's the site of the dopaminergic cell bodies. So that's kind of where your dopamine cell bodies are stored. And then the basal forebrain has different areas that are involved as well in the response. This is just kind of a picture showing the different areas that we just talked about. So you have your prefrontal cortex and your cortex. That's involved in planning and judgment. So that's how we think through things. That's how we judge things. If we're looking at a situation and trying to figure out what we need to do with it, this area of the brain is very much involved in it. The part of the brain that we really see activation of the opioid system and where we see dopamine issue or dopamine responses is the reward system, which is the nucleus accumbens, the medial forebrain, and then the ventral tegmental area. That area is probably the one where people would be most familiar with, maybe not necessarily the parts of the brain, but when we talk about people feeling that high, feeling that rewarding stimulus from their opiate use, that would be the area of the brain that we're really talking about it being affected. And then emotion and conditioned effects are stored in the amygdala. That's where some opiate effects will be seen as well, not as much as the reward system. Like I said, the three areas, the nucleus accumbens, the forebrain, and the VTA, all three of those are your big reward systems. And that's kind of where we see our patients when they talk about their use and that euphoric effect that Zach alluded to earlier, especially that first time use. That's the area that's being activated. And that's where you're going to see a big dopamine surge. And we'll kind of show a picture here in a minute that goes over what that dopamine surge looks like and how a normal response to dopamine takes effect versus when you introduce a stimulant to it. So kind of a brief overview of the receptors we're looking at. The big ones we're looking at, you have several different opiate receptors, but the biggest one is the mu opiate receptor. That is the one that facilitates the rewarding behavior for both opiate and non-opiate substances. And then your dopamine response, that's the big player. That's the one that when anything good happens to you, you have a dopamine response. So you hit the game-winning shot, you ace that test you've been studying for, anything like that, anything that you find rewarding, your dopamine system will get activated. The opiates kind of put that system into overdrive. You have GABA interneurons. They suppress dopamine cell firing and they result in reduced dopamine release. So that's kind of like a counterintuitive thing. And then you have CB1 receptors. Those are activated by cannabinoids, and they can help inhibit the release of glutamate and GABA, which we'll talk about here in a little bit. So again, talking about the big player, talking about dopamine. Dopamine is its initial drug or the initial drug use from and a dopamine release results in relaxation, euphoria, and a variety of other psychological effects. It's mediated by the dopaminergic reward pathway, which we kind of talked about earlier. And the traditional thinking is dopamine release via this pathway is associated with pleasure, and it's more accurately portrayed as indicating an importance to a signal. So when you get a burst of dopamine in this pathway, it can show enhanced importance onto particular stimulus or aspects of the environment, and there's greater motivation to pay attention to the signal. And then drugs of abuse that take over this pathway, they produce super psychologic increases in dopamine, which again, we're going to show a picture here in a second, but it's kind of like if you see these drag cars that you see run on drag strips, if you put a normal car out there or just put that car out there without any of the modifications, it's not going to go near as fast. They input nitrous and different things into it that produce super effects on these cars that make them go extremely fast. That's kind of how you have to look at the dopamine system when these stimuluses are introduced. It's like putting nitrous into your body, almost like you were feeding that drag car. It feeds that dopamine system and puts it into overdrive. And then, as I said, it's going to greatly exceed the normal dopamine response you get to just natural rewards in your body. And then kind of the different pathways in the brain. This is just kind of another kind of layout of the dopaminergic pathways and kind of where they act and how they can go throughout the brain when you're receiving these kind of responses. So again, this is kind of a clearer picture of how when these areas are activated and where all in the brain they can go. So if you're activating the area in the blue, the mesiocortical system, that involves your cognition, memory, attention, emotional behavior, and learning. So anything you do to this area is going to affect all of that. It can affect your memory. That's why if you have these episodes where patients are extremely high from whatever stimulant they've used, they may not remember everything that happened. They may have altered behavior. Their learning abilities and their ability to pay attention are altered by this. If their movements and stuff are slowed down, that's the green area, the nigrostriatal system. And then you've got the pink area, which is the mesolimbic system, which is pleasure and reward and the seeking behaviors. That's the part that these patients are looking for, as Zach alluded to earlier, that very first high that they ever got. They're always seeking to get that again, and they'll never get there again. And we'll talk about why they can't get there here in a little bit. But after that first use, they get that intense high, especially if they're opiate naive. And then they are never able to get back to that initial feeling again. But that's what they're always chasing, because when you use, and going back to talking about memory, when you use and you get that initial high, your body lays down that memory, or your brain lays down that memory and says, oh, I really like that. I really liked how that felt. I'm going to lay down a memory and say, hey, if I do this, this is what happens. And it's the same thing for other rewarding stimulus that you may see. It's going to lay down that initial, it's going to lay down that initial memory of, hey, this happened really well. And you're always chasing that high again. So the instance I use is I'm a big hunter. I like to hunt. And kind of when you go hunting and you kill that first deer, whatever it is that you go after, there's that initial like, oh, my body really enjoyed this. That was great. I love this. And you're always going after that again. It's kind of the same thing with the opiates. So your dopamine receptors, these are the big ones. These are the targets of a lot of these drugs, and these are what are activated and get flooded with dopamine when these drugs are used. You have 5 different types, and they're all part of the dopamine transporter system. There's different dopamine receptors, and they have different roles for the addiction process. And this system in and of itself is the target of a lot of the drugs that you'll see patients abusing, cocaine being just one of the common ones. And again, going back to what I talked about earlier, dopamine reinforces the reward of the drug. So just again, going back to talk about that is when patients use, there's that reward stimulus that takes place, and their brain lays down that memory and they're chasing that again. There's future drug targets, and I've talked to some of my friends I have some friends who do research in addiction medicine. I have some friends who are medical science liaisons for addiction medicine, and there are specific drug targets that have been theorized for dopamine receptors and kind of how they can play a role in addiction. There's even talk of vaccines being available for certain types of receptors and drugs in the future. I had a meeting just this past week with a professor from Stanford who his initial body of work was in addiction medicine and research for different types of drugs and how they can affect. And he was talking about vaccines that may be available in the future that'll target specific areas and target specific receptors. So the role of the dopamine receptors in addiction, three of the big ones are the D1 receptor. That reinforces reward for consuming alcohol. The D2 receptor shows preference for alcohol consumption, and then the D3 receptor, it doesn't show much difference except in the role of drug seeking behavior or relapse addiction. So that's a big one in when patients are seeking, or when they're using and they're seeking behavior, or their big relapse. That has been theorized as a potential target in the future, again, for helping patients relapse, although there's not a lot of research being done into that area as of right now. This is the picture I was alluding to earlier that kind of shows how drugs can increase the release of dopamine. So talked about cocaine earlier. So on the left side of the screen, you'll see like your normal dopamine transport system, and you eat something good, eat something you really enjoy. You have a release of dopamine. Your body's like, oh, this is something we really like. On the right, you see what happens if you introduce a stimulant like cocaine to it. Your body gets flooded with it. So that your body lays down a memory there as well, just as it would eating food, except it's a much stronger memory that, oh, I did this and I got this kind of reward. I want to do that again. But what happens is over time, especially if you continue to use, your body down regulates and gets rid of a lot of the dopamine receptors because it says, oh, I don't need that many receptors to get this response. So I'm going to down regulate it, which means patients end up using more and more each time, which can lead to obviously the potential for overdose. They do build up a tolerance, but at some point they can't tolerate the amount they're doing. So as I said, as you continue to use and use more and more, your body says, oh, I don't need all these receptors because we're releasing a ton of dopamine. So I'm going to get rid of some of these receptors. And that leads to, oh, that's why I don't get that same high feeling as I did the first time we used. So down regulations of receptors is a big player in why patients end up using more and more of a drug each time, or over time. And that's what causes them to have to continue to go up on their dose is there's fewer receptors for the dopamine to hit. So we have endogenous and exogenous opioids. So endogenous, they're inside our body. They were discovered in the 70s, and they have a very similar function to morphine. They give analgesia and mood elevation. And when they're produced, the body also releases dopamine and inhibits the production of GABA, which is another one we'll talk about here in a little bit. The endorphins in your body, they bind to receptors in the limbic system and they produce the effects that we talked about above. And again, it kind of an example of this is when patients say they get that high, or some people will call it a runner's high, people who enjoy running and get that adrenaline rush. And they can also have that after being seriously injured. That's why you'll see people who get hurt and seem to walk away from, say, a really bad car accident or something like that. They have that initial adrenaline rush and that high, and their body's not being allowed to process everything correctly at the time. And then we talked about exogenous opiates, which would be your drugs and things like that that you take and introduce into your body. And as I said earlier, long-term use of those will downregulate the body's regular production, and that leads to potential for dysphoria after discontinuation. So, you'll see patients that will go through issues that are depressive first, for lack of a better term, when they're not using because they're not getting that regular release of dopamine from their body. Their bodies have been conditioned that I take this, I get the release of dopamine, and it doesn't do it on its own, and they don't have all the same receptors because they've been down regulated from the continuous use. So over time, again, like I said, they need to use more and more, but if they stop using, they not only go through major withdrawal symptoms, they don't get that satisfaction feeling, and they don't feel complete like they did when they were using. So over time, that can cause some major issues with them as well. And this is kind of an example of if you have pain or anything that takes place in your body, kind of how it works. So your brain receives the pain signal, it sends it down to the spinal cord. You've got different nerves that are activated saying, hey, we've got pain here. And then it's sent back up to your brain to say what the response is going to be. And then all that's handled and your body has the appropriate response. So you'll have different things like dopamine, GABA release to kind of address any kind of pain or anything like that. And it's kind of the same thing when we introduce outside stimulants. your body is going to send that signal to your brain like, hey, we've got this going on, and your brain's going to send a signal out, okay, this is what we're going to do to address it. So anytime you're introducing anything foreign into your body, or there's an outside stimulant introduced, your brain's going to have a response to it. And so the different opioid receptors, and these are kind of the big players that are targeted by, various opiates and things of that nature. The pharmacologic action of your drugs are mostly exerted on the mu, kappa, and delta receptors. The mu opiate receptor is the one that is the big target. That's the one that is activated by your endogenous opiates that are in your body and the endorphins, and it's the main opiate receptor that is involved in addiction, is the mu opiate receptor. So when you take any kind of medication, and it's kind of, the best way to put it is like a socket and a bolt, kind of, or a nut. When you have a socket, it fits a certain size nut if you're trying to tighten it up. So if you take an opiate, it is looking for where it's going to fit in, and it'll latch onto that receptor and kind of bind to that receptor. And that's what causes it to be able to exert its effect. So it's looking for, most of them are looking for specifically that mu opiate receptor. They're going to find where they fit in, they're going to fit in, and then they're going to exert their effects on that receptor. And once that receptor is activated, that's where you get that whole dopamine cascade that happens, and the big release of dopamine and other things that come with it. The delta and kappa receptors actually play more of a role in combating addiction and their potential treatment options for addiction. So again, I was talking to some of my friends that are medical science liaisons that work in the field of addiction, and they have drugs that have been in development. Some of them are still in some phase 1 trials. There's some that didn't even make it to off the drawing board from the mice examples, but they're looking at the delta and kappa receptors for what can we do with these to help combat addiction in the future. So can we use these? Can we use the same receptors, just a different part of them or a different type of that same receptor, and help actually treat addiction versus, causing a bigger problem? And then this is just kind of a better breakdown of the different receptor subtypes. So again, you've got the mu opiate receptor. It's responsible for the analgesia, the euphoria, the physical dependence, sedation, respiratory depression. So all the things we see, the good and the bad, that we associate with patients who are addicted to opiates or an opiate-like substance, all of that is exerted mostly by the mu opiate receptor. The euphoric effect, again, that's what the patients are looking for, but it also has to do with the physical dependence part. So again, your body gets used to having that stimulus, having a certain amount of that drug and that stimulus present, and that's what it depends on. That's why our opiate patients can get so sick and have such bad withdrawal symptoms, because their body is used to having a certain level of drug in their system to produce that effect. And that's where your drugs like buprenorphine come into play, because they'll still bind to that receptor and they have higher affinity for the receptor than a lot of your other opiates, but they only produce a partial effect. So they're going to alleviate some of those symptoms and cravings that our patients have without producing near as much sedation, respiratory depression, those other things. And the big thing, and what most people, if they overdose, are going to die from on opiates, is the respiratory depression. Their breathing gets so shallow and so infrequent that they're starved of oxygen. The delta receptors, it also has some to do with analgesia, but it inhibits dopamine. So it inhibits the reward. That's again why that one's kind of being looked at as a drug target, because if we can inhibit that reward, if we can put something in there that if they take an opiate or they don't get that reward, that's gonna lead to them not seeking near as much, because they're not getting the same reward they used to. The kappa receptor, same thing. Minor player in analgesia, but dysphoria. So if they take this and they have a dysphoric effect, that's going to lead them to not use as much. You got another receptor that's a subtype that's an ORL1 opiate-like receptor. The big thing to note about that receptor is the decreased withdrawal. That has been, again, I was talking to the professor from Sanford, and we were talking about different targets and just the different receptor types that can be targeted for drug use and helping patients get through this. So the OLR1 receptor decreases withdrawal. If we can find a drug that could target that receptor and help our patients get through their withdrawal just a little bit better, that would be something huge for them. And it's been a potential drug target. There's been a few drugs in development, nothing that's gotten past phase 1 that I'm aware of, that I'd have to look into it and see if there's anything. But the last time I checked, there wasn't anything that had gotten past phase 1 targeting this receptor yet. So this chart just kind of shows you the different types of agonists that we have. So you have your full agonists, which would be like your morphines, your oxycontins, heroines, things of that nature are your full agonists. They bind to that receptor and they let that receptor act to its fullest potential. So that's why when patients get that outside opiate introduced, no matter what it is, whether it be fentanyl that they're shooting up, whether it's heroin, whether it's oxycontin they're taking by mouth or they've crushed and shot up, snorted, whatever it is, that goes in, binds to your opiate receptors and releases them completely. It lets them have their full action, do everything they're going to do. Then you step down to more like your buprenorphine. So if a full agonist is 100% activation, we can look at a partial agonist as kind of no activation or half of activation. So your buprenorphine products, your Suboxone, things like that, they're going to act on these receptors and they're only going to activate it to a small degree. They're not going to fully activate the receptor, but about 50%. So that's why we like to use these drugs in helping treat addiction, because they still give that patient a little bit of that stimulus, a little bit of that reward that they're looking for without fully activating. It helps alleviate their withdrawal symptoms, but it still gives them just a little bit of that reward stimulus. And then you have a neutral agonist, so something that just binds to the receptor. This would be more like a blocking agent, like your naltrexone, naloxone, things of that nature. That would be, those kind of bind to the receptors and just block it and don't let the drug act on it. So if you have a patient who's taking naltrexone, they're taking naltrexone, they receive an injection of naltrexone or they take the oral pill, either one, and they go to try to use. They don't get any kind of response because the receptors have been blocked off by the naltrexone. The problem with that is patients will try to override that. So they're like, well, I'll just take more. And eventually they might override it, but the problem is they're going to end up, most of the time, they're going to end up overdosing themselves, because although they're not getting the euphoric effects, it's hitting those other subreceptors and causing respiratory depression and things like that. And that's what ends up killing patients from overdose. They're going to take so much of it and not ever have that euphoric or analgesic effect, but they're going to get all the other bad side effects like the respiratory depression. You have inverse agonists, and those kind of have the opposite effect on the receptors. They're going to kind of shut it down and have the opposite effect of your full agonist or your partial agonist. And I've seen some questions coming in, and when we go back through the chat, I'll kind of address those as well at the end. And then the role of opiate receptors in addiction. So one of the studies that I like to reference is they had genetically modified mice that had some of their receptors removed, and specifically they had no mu opiate receptors whatsoever. So they lost all of the reward stimulus from taking any kind of opiate that targeted these systems. What you also saw, though, is they had an increased sensitivity to pain. They also had reduced reward to non-opiate substances too, though, because alcohol, cannabinoids, and nicotine, because those will still activate those receptors to a much lesser degree. And they had altered emotional responses. So we talked about how the dopamine system and these reward pathways can be involved in your emotional responses. They had altered emotional responses to just their normal everyday, stimuli that were introduced to them. One of the things I saw in chat was they're talking about pharmacological addiction, but the question was, do these receptors respond the same or similarly for gaming, porn, non-chemical addiction as well? That's a great question. And yes, those same receptors are involved in addiction to these other things as well. So gaming being a big one for like teenage boys and things of that nature, you'll see like when they're playing a game, those games are specifically designed to hit those dopamine pathways and give that reward stimulus. So it's the exact same response that you're going to get from these opiates and things that you take. It's just a visual stimuli versus one that you take or that's normally in your body. So those are targeting more of that normal your normal body pathway. Your body's doing that all on its own, but those games and things like that are specifically designed to hit those systems and produce that stimulus. But that's also why you'll see the same thing with gamers and people who are addicted to gaming is they'll start playing a game and they do something good in it. They get that reward response from dopamine and they're like, "Oh, I want to do that again." So they play more and more, but the response becomes less and less because they're doing it so much and releasing so much of that dopamine response all the time. Their body gets used to it. So that's why you see them increase their gaming time over time because they're looking for that same initial response. So yes, it's exactly, although you're not taking anything, it's the same basis for the reward pathway. Something good happens and your body responds to it, and you're like, oh, I'm going to do that again. That was a great question. So another thing that's involved in addiction is glutamate, and it's an excitatory neurotransmitter. Most of your drugs of abuse will modify the release of this in some way or another. Some interact directly with it. And so an example of that would be alcohol, but most of your drugs are going to interact indirectly by modifying dopamine, which can then cause a release of glutamate. So, i.e., you take cocaine or some kind of opiate like that, it's going to modify your release of dopamine, which will then modify the release of the excitatory neurotransmitter glutamate. This has been theorized again to be a potential drug target. If we can control how this is released or how this is released in response to a stimulus, we can help control addictive behaviors. And exactly what some of the drug studies have shown that if we can decrease or block glutamate release, we can decrease drug use. There's several studies that have looked at blocking the NMDA receptors, and it's one of the main glutamate receptors. And overall self-administration, when this receptor specifically is blocked, overall self-administration of drugs has decreased. So again, this was one of the ones that the professor I was talking to at Stanford, his company that he used to work for was looking at was glutamate and kind of how can we modulate its response and how can we modulate how it goes and how it's released, and then showing kind of what the results are if we do stop it. There's some other subreceptors of glutamate, the ionotropic and metatropic. There's different theories and different drug targets for these. The group 2 receptors are widely expressed in brain regions relevant to drug-related behavior. So again, this was kind of one of the sub-receptors that same company was looking at, kind of how can we work in this area of the brain and kind of decrease the reward behaviors with drug use. There's been some preclinical models that have been shown to regulate both the reward processing and drug seeking behavior. So again, that's going to be a big part of future drug targets, is not only how can we help treat these patients, help treat their symptoms, but what can we do as far as reducing the effects they see from these drugs that will help them not want to use as much in the future. Again, I've got several friends who work in this field. I've got several colleagues that I've dealt with over the years that have worked in these fields, and there's some exciting things possibly on the horizon that just haven't been released yet. And the problem is finding things that work not only in your preclinical like mice models, but also, in human models that make it to your human trials and work in humans as well. We've seen several things that show promise in mice models, but don't necessarily translate over to humans. So the MGUL2 and 3 receptors, the group 2 receptors, they appear to control dopamine and glutamate release in the addiction-related parts of the brain. And again, it's a new therapeutic target that's got exciting potential for drug use in the future. There's just not anything out yet that covers these and is available on market yet. But if we can target specific receptors that are involved in addiction and use those to our advantage, that would be huge and great for future drug targets and for helping in the future. And again, kind of the different receptor targets. Opiates, they mimic what's already in your body. The euphoric feelings, modulation of appetite, stress reduction. Your body does that all on its own. Opiates just kind of put that into overdrive. Cocaine, kind of the same thing. The GABA or the benzos, they facilitate the function of GABA, and they lead to a reduction of anxiety. And then alcohol kind of works in that same area. They facilitate the activation of particular GABA receptors and inhibit the function of NMDA, which we talked about earlier. And that's what's related to the intoxicating effects of alcohol. So lots of options for drug targets. The problem is finding drugs or finding chemicals that will work in your body but not cause detrimental effects as well. And again, we've seen promise in some mice models in some of these things, but when they make it to human trials, or they never get to human trials because we see that there can be detrimental effects. So that is all that I have. I will stop sharing my screen and I will turn it over to Jennifer for the next part of our presentation. And again, I saw several of the questions coming in. We'll address a lot of these at the end.
Right, we are going to get started. Get started back. My name is Jennifer. That says Dunkin, but it's Dunkin without the G. I am the Assistant Director of Nursing at Bradford Health Services in Warrior. It's an inpatient facility. Prior to being the Assistant Director of Nursing, I was the MOUD/MAT nurse for 6 years. Pretty much when we started offering all MAT services, I became the nurse that specialized in that. Patients would come and talk to me. We discuss their options, decide what medication was best for them, and then help facilitate getting them started on it. I do have an associate's degree in applied sciences as a registered nurse. I also have a bachelor's degree in criminal justice with a minor in psychology from UAB, so go Blazers. I'm also a certified CPR instructor for Bradford for BLS services. I have worked at Bradford for 24 years, so I've been there for a very long time. So we are going to talk about bridging the gap between use and treatment and medication. So only 31% of illicit drug users receive any kind of treatment for addiction. That was in 2018. I think we're seeing maybe a little bit of an increase in that thanks to the marketplace offering insurance. A lot of patients that we currently have experience homelessness. So, and they're unemployed. So them being able to get insurance through the marketplace has helped them to get treatment. So of that 31% that received treatment, only 20% of those were treated by an addiction-focused facility. So that number starts to get smaller. Of that 20%, 31% of the OUD patients and 37% of the heroin use patients received MOUD, but too short and low dose. So a lot of that is contributed to stigma from not so much staff anymore, but even our patients have their own feelings of stigma. Some believe that it's trading one drug for another, when that's not really the case at all. So a lot of times our patients have a hard time switching to an MOUD to take on a long-term basis. So patients that discharge with an OUD or that have an OUD that do not take any form of medication-assisted treatment, they have an 80% chance of relapse. If they are on medication, they have a 50% chance of relapse. So while I was the MAT nurse, I used to lecture to our patients, and that's what I would tell them. I would tell them that their risk of relapse was much greater without medication than it was with medication. So we are going to talk about the medication and the barriers. So this shows you, this is an example of the receptors in the brain. It shows you how each one of these medications work. So methadone is considered a full agonist. So what it does is it fully covers that opiate receptor in the brain. The way that it helps our patients is that it has a higher affinity. Your brain has a higher affinity for methadone than it does any other opiate. So what I tell my patients are, your brain likes methadone more than it does any other opiate. So that's how it helps. It helps reduce cravings. That's how it helps you maintain recovery. Because if you, not that we recommend it, but if you were to use while taking methadone, you're really not going to get any effect from it as far as like the euphoric effect, because those opiates are not going to knock the methadone off of those receptors. So buprenorphine is partial coverage, which is considered a partial agonist. So what it does is it partially covers the receptors in the brain. Again, it helps your patients maintain their recovery by, by your brain having a higher affinity for buprenorphine than it does any other opiates, other than the methadone. So, using any opiates with buprenorphine, you're not going to get any effect from it. Buprenorphine even has a higher affinity than fentanyl. Carfentanil does not. Carfentanil has a higher affinity than buprenorphine. So recently, probably within the last year or so, one of the counties close to us had found some carfentanil in some of their fentanyl that they seized. And when talking with our patients about it, when they asked why they were still able to get high, we told them we don't really know, but it probably is because there was something other than fentanyl in there. And that's what people do. They realize that once patients aren't getting, not patients, but, using outside, if they're not getting high, the dealers are going to change what they're adding to it so that they can, they can get high off of it. That way they'll buy more products. So, and then there's naltrexone that is offered. So naltrexone is a opiate blocker. So it's a full antagonist. What it does is it sits on top of the opiate receptors. And then if there's any use while someone is taking naltrexone, basically what those opiates do is they bounce off the naltrexone. It never attaches to the opiate receptor, so they don't get that euphoric feeling of being high while on naltrexone. It's very important that your patients get education about the medications as far as if they were to use with them. We stress to our patients that using these medications, using with these medications, while you may not get the euphoric feeling, you'll get the physical feeling. So you'll still have, or the physical reaction to taking opiates. So you'll still have the respiratory depression. There's still a chance of, overdose and death if they use on top of these, and they won't necessarily feel it. So education is very important when discussing medication options with patients. So with medications for opiate use disorder, we use the harm reduction model, which is, the risk of relapse versus the benefits of harm reduction. So one of our previous medical directors said it best when we first started offering medication services was you can't treat dead. So, and it's really true. So we might, think they need to be on one certain medication, and then the patient decides they need to be on something else. Well, it's their life. And if it keeps them from going back to illicit use, and it keeps them from doing those other things that are involved with illicit use, stealing, pawning, not being able to keep a job, things like that, then that's what, that's what we encourage and advocate for them to do. The goal is for our patients to return, to society, to keep jobs, to have families, to have a house, have a car, all of those things. So, whatever medication they feel like is going to work for them, then that's what we're going to advocate, and what you should advocate for them to take. As far as recommendations about which medication to take, when you should stop it, there's no set time. There's no set medication that's best for everyone. It's all individualized. So what might work for one patient might not work for the other patient, and that's okay. You just have to talk with your patients, figure out what would be best for them. We always recommend our patients stay on their medications for a minimum of a year. And that's because that allows them to get a good foundation in recovery, allows them to get a sponsor, allows them to work the program, to get counseling before they decide to come off of it. But at the end of the day, if they don't decide to come off of it, that's okay too. You have to think of it, and I think most of us probably do, you have to think of it like a disease. So therefore, it's no different than someone that has high blood pressure. Yes, there are lifestyle changes that can be made that can, that can better their lives, that can cause them to not have to take medication, but at the same time, they can do all of those things and they still have to be on medication. We don't look down on the people that take blood pressure medicine. A lot of people also equate it to people with diabetes. And I have a son that's a diabetic, so I feel extra qualified to talk on that. But it's the same thing. You can make lifestyle changes. If you have, type 2 diabetes, you can make certain lifestyle changes to where you may or may not have to take medication, but at the same time, you may take those, do those lifestyle changes and you may have to take meds. We don't look down on them. There's no reason we should look down on people that have an opiate use disorder that need to take medication in order to, live the quote unquote normal life, in order to keep a steady job and all that, and take care of their family and take care of themselves. It's really no different. So, like I said, the goal is at least 12 months, but again, it's individualized. I caution my patients if they want to try to come off their medication prior to 12 months, that they really need to speak with their counselor and their sponsor, and other, trusted people in the recovery community, and make sure that they have a very solid plan of what's going to happen if they decide to come off their medication and then, start having increased cravings, or anything like that. So, with medication, it tends to quiet the brain, quiets the cravings, the excessive thoughts, to allow the individual to focus on treatment and recovery. Like I said before, it allows individuals to live a productive, functional life from substance abuse. It also improves clinical outcomes for individuals with serious mental illness. What you've probably found with patients that you've, talked with, treated, that have substance use disorders, a lot of them also have mental health issues. And a lot of them have mental health issues that have not been addressed, have not been diagnosed, or have been diagnosed and they're not being treated for one reason or the other. And they've turned to substance use in order to help alleviate those symptoms of mental illness. So when you get them on, MOUD medication and medications for any kind of mental illness that they might have, they tend to have much better outcomes for them. So here's the model. We also stress with our patients that medication is not the only answer. It's not a magic pill, or strip or injection or whatever that you can take and you're magically cured. So it's medication along with therapy. So, we encourage and advocate for our patients to see individual counselors, family counselors, marriage counselors, to do, intensive outpatient, to do all of those things along with medication. That is what gives them their best chance at maintaining their recovery. So with withdrawal, once they're physically dependent, they get rebound hyperexcitability when their drug is stopped. So if you've ever taking care of a patient or been with someone that is going through opiate withdrawals, it is rough. They feel really terrible. They have the abdominal cramps, muscle aches, nausea, vomiting, diarrhea. They may yawn excessively. Their pupils will be dilated. Their blood pressures will be, increased. Heart rate will be increased. Their anxiety. They'll have skin crawling, runny nose. All of those are symptoms of withdrawal. We use the COWS in order to measure our patient's level of withdrawal, which is a clinical opiate withdrawal scale, and then medicate them accordingly. So the onset, duration, and symptoms often depend on what type of opiate that they're using. So methadone and Suboxone usually, or buprenorphine, usually take longer for the withdrawal effects to come in, and that's because their half-life is longer. So it's usually within 48, 72 hours. With fentanyl, they're usually having withdrawal symptoms within 24 hours. And then some other opiates may take longer. I will say with methadone, they usually go into full-blown withdrawal, usually within 72 hours. But with methadone, when that first dose is missed, they start having withdrawal symptoms. So if your patient decides to be on methadone, you want to make sure that you educate them on the importance of taking their medication every day, because they will start to experience some withdrawal symptoms as soon as they miss that first dose. So we do a symptoms-based approach, which is what most everyone does, until the patient is able to start buprenorphine. So we start buprenorphine based on their COWS score and also when they last used. So in the age of fentanyl now, we are typically having to wait anywhere from 48 to 72 hours, sometimes even longer, to start them on buprenorphine. Otherwise, it will, they end up going into precipitated withdrawals, which are basically immediate withdrawals. All of those symptoms I described earlier, they get all at one time, and they are truly miserable. So we try to do everything we can to avoid that. And they're usually pretty uncomfortable by the time we can actually start the buprenorphine. So we do a buprenorphine taper, and it can be advanced to the buprenorphine MOUD, which they take on a daily basis, or they can choose to taper off and choose to get started on naltrexone. As far as Bradford, we only offer buprenorphine and naltrexone. We are not licensed in any way as a methadone clinic. So that's why we don't offer it. But You would just, if your patient wants to be on methadone, and you don't offer it, you would just need to, coordinate getting them referred to a clinic. We also give clonidine as needed, usually every 4 hours, specifically for opiate withdrawal. So clonidine is usually given for blood pressures, like high blood pressure. You may know people that are on it for their blood pressure. But it's also listed as a quote unquote other analgesic. And what they found is that taking clonidine, it helps with just the overall, bad, crappy feeling of opiate withdrawal. So, we here do it every 4 hours as needed, as long as their blood pressure can tolerate it. And it usually, it helps a lot more than people think it does. So, that's another option. There is a new one that came out recently that is like clonidine, but is not supposed to drop the blood pressure as low. I believe, if I remember right, it's Lucimira. We've not really started using that yet, but that could be another option for patients, especially if patients are at home. So medication is the gold standard of treatment. Again, it's the harm reduction model. We want to keep them alive in order to treat them. So, whatever that takes, meeting them where they are, as far as where they are in their recovery, and what they want to do. We meet them where they are, and then keep them alive until they want to make changes. Evidence shows that if you participate in MOUD, you tend to remain engaged in treatment longer, and that's because it helps reduce those cravings, helps reduce any of those withdrawal symptoms, so you're able to focus. Because, if you've ever been sick, if you've ever been in pain, it's hard to focus on anything else when you feel bad. So, the sooner we can get our patients started and feeling better, the more engaged they are in treatment, and the more likely they are to achieve long-term recovery. So again, the medications for MOUD, there's naltrexone. It can be given as a tablet that you take once a day, or an extended release injection, which is called Vivitrol. There's buprenorphine. The brand name is Suboxone. There's a lot of other, I think there's Subzolve. I think there's another one that I can't think of right now. So buprenorphine can be given as a strip or a tablet, and it's placed under the tongue to absorb into those mucous membranes that are in your mouth. There is also an extended release injection. There's actually two. And I see that. So one is Sublocade. Sublocade's been around for a little bit longer. It's an injection that goes into the stomach. It is just buprenorphine. It lasts for 28 days. And then the new one is Brixadi. It just recently was approved for US release, I believe, in September. And they offer with Brixadi a weekly or a monthly injection. So your patients are struggling with, getting to their next injection, the weekly injection may be an option for them. And then, of course, there's methadone that is an option for MOUD. Methadone has been around the longest. Methadone's been studied the longest. It probably also has the most stigma surrounding it. Methadone does work, and the studies have shown that it does work. So, if your patient decides that they want to be on methadone, you just educate them, and you don't want to have any stigma towards them about taking methadone because of, anything that you may have heard or seen or experienced. There's a reason there are hundreds of thousands of methadone clinics all over the US, and there are probably, the same amount of people that are patients at methadone clinics that you probably would never know unless they told you so. So again, naltrexone is an opioid antagonist. It blocks the opiate receptors. Then there's buprenorphine, which is the partial opiate agonist. So it partially sits on those opiate receptors. And then methadone is a full opioid agonist. So it completely fills and fully fits inside the receptor. So the sheet that you also see on this slide, this is an education sheet that we give our patients for them to read over and to discuss before they decide what medication that they want to be on. You want to go over the potential side effects. A lot of patients get really worried about the potential side effects. And, what I have to remind them is that every medication has side effects. So Tylenol has side effects. Ibuprofen has side effects, and some of the side effects are as severe as the potential side effects of any of these medications. So, they just have to read over it, really think about what they want to do. But the most important thing is to have them choose one of those medications, if possible, to be on while they work their recovery. So here is another I guess slide of how the receptors work, how the medications work in the receptors. So the little one that looks like a Y is the empty opioid receptor. You see how methadone fully sits on top of it and completely covers it. Buprenorphine partially covers it. And then naltrexone, it sits on top of it and blocks it. And then there's the impact of different medications on the opioid receptor activation. So, if they're using an illicit opiate, it tends to activate the receptors fairly quickly, and then it tends to taper off. Whereas the MAT, the buprenorphine and the methadone, it tends to have a slower activation time, but it also keeps them activated longer. So this is more information about the difference between a full agonist, a partial agonist, and an antagonist. There is, again, methadone is the full agonist. There's buprenorphine, the partial agonist, and the antagonist, which is naltrexone. And it says naltrexone is Vivitrol or Rivia. Rivia is the brand name, and I don't even think they make that anymore. So methadone can be given in a pill, a wafer, a disc. I've had patients tell me different things. Some have told me they don't make the wafers anymore. I'm not really sure. With methadone, you have to go to a clinic every day in order to get dosed, at least in the beginning. With partial agonist, there's the pill form or film, an injection. There is a buprenorphine patch. It's typically mostly used for pain management. I do not believe the implant is available anymore. I believe they took that off the market. And then with naltrexone, there is just the pill or the injection that they can do. So research indicates that MAT or MOUD with methadone or buprenorphine can improve client survival and decrease mortality related to opiate use. And that's because, methadone and buprenorphine have a higher, your brain has a higher affinity for them. So when they use illicit opiates or other opiates, they're not getting any euphoric feeling from it. So for a lot of patients, once they realize that they're not going to get that feeling from it, they, decide why continue to use. So they improve treatment retention. Again, that's because it helps quiet those cravings, helps with withdrawal symptoms. Again, if you're feeling terrible, you're not thinking about anything else other than how bad you feel. So the quicker we can get our patients feeling better, they can be more engaged in treatment, and they're more likely to stay in treatment. So you're going to decrease the opioid use and related criminal activity because they're going to the doctor, they're getting their medication filled at a pharmacy, they're paying their copay. They don't have to steal or pawn or anything like that to pay a drug dealer to get their medication. So, that's another positive outcome. They're more able to obtain and maintain employment. And that's because they're not having cravings, they're not having withdrawals, they're not having to do criminal activity in order to get, opiates. So they're able to, focus on their jobs, getting a job and maintaining it. So it improves birth outcomes for pregnant women with substance use disorders. And that's because The main thing with pregnant women is you want to prevent any return to use. I did a webinar about OUD and pregnancy, and all the research shows it's, that the more healthy you can make the mom, the more healthy that the baby's going to be. So healthy mom, healthy baby. And if they're not, using opiates, they're not using IV or anything like that, that's definitely going to improve their birth outcome for the baby. So most babies, when they're born, whether the mom has taken buprenorphine or methadone, most babies do not require like extended stay. Sometimes they do, more so with methadone than with buprenorphine. But they do not require extended babies don't require extended like NICU stays. A lot of times they don't require medical intervention. Usually they just require like low lighting and swaddling, and they're able to go home with mom. So there is a decreased risk to contract HIV or Hep B or C, and that's because they're not using illicitly, and they're not shooting up. So, which means they're not sharing needles. So that reduces the potential for relapse. Again, it calms those cravings, helps them focus on working their recovery, seeing their counselor, doing IOP, working their steps, whatever they decide that they're going to do. It enhanced social functioning. They don't feel like an outcast. There's a lot of shame with use, with drug use. So, they're able to function in family functions because they don't feel that shame because they are, they're taking medication. So research indicates that injectable naltrexone may be able to also decrease the rate of relapse over 24 weeks. There's a longer median time to relapse. And the studies that were done for that were particularly long-term studies. Sufficient evidence for naltrexone is limited. The main thing with the naltrexone is, you have to, they have to come every 28 days in order to get their injection. So sometimes it's hard to keep them engaged, especially if it's in a outpatient or an IOP setting. Sometimes it's hard to, to keep them engaged for 28 days to make it back, or they think after 28 days, oh, I feel great, everything's fine, I don't need another, I don't need another shot. So you just, again, have to educate. So naltrexone can help maintain abstinence, increase retention and treatment, prevent relapse. This is short-term outcomes to reduce overdose and overdose-related deaths. Again, the most important thing is that they're on something. So the naltrexone, if your patient decides to be on naltrexone, you want to make sure that you educate them about not using while on naltrexone, because while they will not get the euphoric feeling of being high, their body's going to react to the opiate. So there still is a chance that they could have an overdose and just not feel it. And a lot of times when I tell my patients that, they, I don't want to do that. That usually is a good deterrent for them. We've had patients that have tried to override the naltrexone. It's just not, it doesn't happen. I'm sorry, I lost my train of thought. It just doesn't happen with overriding it. Usually if they override it, it's usually like more than 28 days after their last injection. So Vivitrol effectiveness, Vivitrol is the injectable naltrexone. The IM route, which is intramuscular, it improves adherence and increases treatment retention. So the injection lasts 28 days. It is an injection. It forms a depot, which is like a hard spot where it's given. And, it helps increase treatment retention and improves adherence because it lasts 28 days. Therefore, once you get the injection, you've made that decision for the next 28 days. So it's not where it's a pill or a film where they can decide, oh, I'm just not going to take it. Once they make that decision to get that Vivitrol and get that injection, they've made that decision. So more time in treatment allows the clinical team to provide patient with tools to live a sober life. Many patients report feeling secure knowing that they can't use with Vivitrol. Again, like I said, you can't override it. And then again, it's not uncommon for patients to test the effect by using. Usually what they realize is that they get no effect from it. They've just wasted their money. And so they're not going to do that anymore. So issues with Vivitrol, it is expensive if you do not have insurance. I'm trying to remember I think the last cost that I heard of, it's about $1,500 if they pay out of pocket for it. If you have a patient that does not have insurance, I would suggest and encourage them to get on the marketplace and see if they can get a policy that's inexpensive or free for them. And almost all of those policies will cover Vivitrol at little to no cost for them. Vivitrol also offers a copay assistance program where they will cover up to $500 of any out-of-pocket that patients might have towards the injection. They also have a patient assistance program. Basically, you fill out your patient fills out an application, provides proof of income or lack of income. Usually they have to provide bank statements for the last few months. You fax all of that in. If they get approved for the patient assistance program, they'll be approved for 6 injections up front. So that's a good way, that's another way that they can get the Vivitrol. So look into that if your patient decides they want to do Vivitrol and they don't have insurance. With the patient assistance program, they cannot have insurance. So if they have insurance and their copay is too high, and it's more than the $500 copay, then, maybe have the patient talk with a specialty pharmacy that's providing the injection. We have had a few of those recently that have their own patient assistance program where they help spread out the payment for the out-of-pocket for the injectable. So that's another thing that you could look into. The route may be an issue with Vivitrol. It is a large injection. If there are any healthcare people in here, it is a 4 milliliter injection. It does go into one of the gluteus medius, which is basically one of the butt cheeks. And you alternate cheeks every 28 days. That's the only place it can be given because it's the only muscle that can tolerate that much. And if we have any nurses in here, they probably cringed because if you were like me in nursing school, they said no more than 2 milliliters, no matter what. But this one is 4, so it's a huge injection. And it is a fairly long needle. So sometimes that can be a deterrent, especially if patients don't like needles or injections. So non-compliance is also an issue with Vivitrol. Again, like I said, it's 28 days, but you gotta, figure out how you're gonna motivate your patient to come back after that 28th day to get another, to continue getting injections. So the demand for prescribers way outweighs the supply. There are many providers that are still not familiar with the medication. We have a lot of patients that want their primary care doctor to be able to give them the injection, and a lot of primary care doctors will not do it because they don't know anything about it. So that is definitely a place that there needs to be some, education and marketing, especially in the primary care, sector. If more primary care doctors were able to give naltrexone, to give Vivitrol, I think we'd see more patients being more, they would get the injection every 28 days. Because a lot of the places that do give injections are not close to people's houses or jobs, and it's inconvenient, and they don't really want to have to do that. But, you know, if it's their primary care doctor that they go and see anyway, you know, they're more likely to get the shot and stay on it. The side effects / risk, often a deterrent for many patients. Like I said earlier, we give them education sheets that go over the side effects of it. And we discuss those with patients, but we also, you know, let them know, yes, there are side effects, but so does every medication. And usually when you put it in that perspective, they feel a little bit better about the side effects. That's also typically why we give our patients the naltrexone pill before we start them on Vivitrol. That way they know if there's going to be any side effects. They'll know with a pill that only lasts, you know, 24 hours, and an injection will last 28 days. So buprenorphine maintenance, it can decrease or eliminate opioid use, including heroin. You know, there's not much just pure heroin out there anymore. It's all got fentanyl in it. Increase overall well-being and social functioning. Again, they're not having that shame with, you know, their illicit use. And so they're able to feel better about themselves. They're taking better care of themselves. You know, and they don't feel that shame around family and friends. It helps to reduce cravings because it is a partial agonist and it partially sits on those receptors. It helps reduce withdrawal symptoms because of that as well. It increases treatment retention because it does help them feel better. It helps reduce those cravings and their, you know, and obsessions in their head about using. It reduces the potential to contract HIV or Hep B or C. Again, that's because they're not using illicitly. They're not using IV. So you don't have to worry, you know, they don't have to worry about sharing needles with anybody or anything like that. And then decreased mortality because it is a partial agonist. And the brain likes it more than it does most other opiates, including fentanyl. When they use, they get no effect from it. Usually it only takes at one time, like with the naltrexone or the Vivitrol. They get no euphoric feeling from it. They don't get high. They realize they wasted their money, and they, you know, then they're like, oh, I don't want to do that anymore. We've had a lot of patients that have done that. So it helps protect against, you know, mortality, which again is the ultimate goal, is to keep, you know, our patients alive because we can't treat dead. So the benefits of buprenorphine, again, it reduces opiate cravings and withdrawal symptoms. It has limited side effects and contraindications as far as what medications that you can take with it. I would caution strongly if any of your patients are also on any kind of benzos, that they, whatever doctor's prescribing them, switch them to something that is not a benzo. Benzos with buprenorphine greatly increases their risk of overdose. I had seen a study where the majority of overdose deaths that patients had buprenorphine in their system, they also had benzos in their system. So what I tell my patients is there are, you know, hundreds of, you know, or thousands of other medications that they can take for whatever they're being prescribed these benzos for that are not going to increase their risk of an overdose. There's less abuse potential than methadone. And less likely to result in any harm if it's misused. And that's because buprenorphine has a ceiling effect. So, you know, what I tell my patients is you can take your entire bottle if you want to, but your brain is only going to process 32 milligrams. And that's it. And the rest of it's going to be wasted. So, you know, taking their whole bottle's not going to really do anything to them. Whereas they take significantly more methadone, they're more likely to overdose and have an overdose death. So buprenorphine is a little bit more beneficial in that way. It is dispensed by licensed and trained physicians and some clinics. They have recently done away with the X waiver, which used to be a specific waiver that physicians and prescribers had to have in order to prescribe buprenorphine. But they've done away with that. Now they just have to do a 8-hour course with the DEA, and then they're able to prescribe buprenorphine. So that is going to, or should drastically help with patients being able to find doctors that will prescribe their buprenorphine for them. And it may, which will also make it more available where methadone is not. Methadone's usually in, big cities with public transportation and, lots of people where, regular, and you have to have all these special licenses in order to prescribe methadone that you do not have to prescribe buprenorphine. So, there is a culture change that's happening where more physicians are being more comfortable with prescribing buprenorphine because they don't have to get that extra license from the DEA. So, one of the potential issues that we're currently finding with buprenorphine, and I think it's in another slide, is that we are finding issues with patients getting their prescriptions filled at pharmacies. And that's because either the pharmacy doesn't carry it at all, or they don't carry that strength, or, there is a specific pharmacy right now that currently has a policy in place where they will not fill a prescription for any kind of controlled substance if the prescriber is more than 50 miles away from them, or if the patient's address is more than 50 miles away from them. So, if any of you work in any kind of, treatment facilities, you have patients from all over that come. It's difficult to try to make sure that they get their medication filled before they go home at a local pharmacy. That way there's no issues. Luckily, we've had some local pharmacies that we've been able to get relationships with so that they will fill our patients' medications. Otherwise, you don't want your patient to go back home 2 hours, 3 hours, however many hours away and not be able to get their medication. So buprenorphine and fentanyl in patients with higher tolerance to the effects of opioids. You may sustain high plasma concentrations of buprenorphine significantly reduced the magnitude of fentanyl-induced respiratory depression. So buprenorphine reduces the harmful effects of fentanyl on ventilation and protects against fentanyl-induced respiratory depression. There was another webinar that I attended where they said with fentanyl using with some patients, because of the amount that they use, they had a respiratory depression. Basically, they called it wooden chest, which is where it, didn't allow the lungs to inflate or air to move like it should. So, we caution our patients, against using fentanyl at all, but that could also be a potential side effect of using too much fentanyl, as you get that respiratory depression, and then you get basically where you can't move air back and forth, and you get Narcan, and it reduces the opioids, but it doesn't reduce, it doesn't help that respiratory depression. So fentanyl lingers on the mu receptors longer than any other opioids. So there needs to be a longer time before induction to buprenorphine, or else they'll be into precipitated withdrawals. We talked about that earlier. What we're seeing is usually we're having to wait 48 to 72 hours after their last fentanyl use, and there are some patients that we've had to wait even longer. Some patients by that time feel so awful they don't care, and they're like, just go ahead and start me and we'll just work through it. So taking buprenorphine too soon after their last use of fentanyl could cause them to go into precipitated withdrawals, which are pretty bad. So misuse of buprenorphine, there is a potential for abuse with it. These findings suggest that among adults with OUD, prevalence of buprenorphine misuse has trended downward from 2015 to 2019. In 2019, nearly 3/4 of U.S. adults reported in the past year that they did not misuse their buprenorphine. Most who misused it reported using prescription opioids without having their own prescription. So, and then a 2023 study indicated that an increased buprenorphine access during the COVID-19 pandemic was not associated with increased proportion of overdose deaths involving buprenorphine. And I think that's because, we were able to get our patients, more patients on buprenorphine, therefore protecting them, also helping them with their cravings, and protecting them and helping them not to go back to their illicit use. So, past year prescription pain reliever misuse in 2022. So this is a graph of any kind of prescription pain reliever that's been misused. So half of individuals with a buprenorphine prescription will share or sell at some point, sell at least some of their prescription. Probably not as much as others. Buprenorphine is comparatively safe compared to other opioids. Of the more than 27,000 buprenorphine exposures reported to poison control from 2003 to 2019, there were only 84 fatalities, which is 0.3%. So that is very, very low compared to other opiates. Supply issues, again, that's what we were talking about earlier. Supply issues with buprenorphine. Studies found that 20% of U.S. pharmacies do not provide buprenorphine. They often follow self-established quotas that leave little to no room for growth to meet demand as prescribers write more prescriptions. Many pharmacists fear ordering too much buprenorphine will trigger a DEA investigation. That is probably still the case. That was in research in Kentucky and North Carolina. A lot of pharmacies, maybe it is a self-established quota. A lot of pharmacies will say we only can order this much buprenorphine on hand. We won't be able to fill it, or we don't have that dose, or we don't keep it at all. I think a lot of them just don't keep it at all because they don't want to have to deal with the regulation, not the regulations, but the reporting of it. So filling Subutex versus Suboxone, your patient should really only be on Subutex, which is just buprenorphine. If they have a anaphylactic reaction to naloxone, most people do not. Most people do not like the buprenorphine films. They don't like the way it tastes. Sometimes they complain that it gives them a headache, or it upsets their stomach. What we tell them is, take something for your head. Don't, once you let your buprenorphine dissolve, don't swallow it. Don't swallow your spit it out. That has alleviated a lot of those symptoms. Or buprenorphine is what pregnant women is prescribed for pregnant women. So that is considered safe. That's the one that's had the most research, other than the buprenorphine naloxone. So, and then again, filling prescriptions for those who travel out of state. We're in Alabama. If we have patients that live in Tennessee, especially Tennessee, they have regulations about filling out-of-state prescriptions. So usually our patients have to get their prescriptions filled in Alabama, usually close to the facility before they go back to Tennessee. Otherwise, they're not going to be able to get their prescriptions filled. So if you have patients that are from different states or from far away, you want to make sure that you work out a plan with them about how they're going to get access to their medication, whether it be when they go home or before they get home. So there is the depot buprenorphine, which is the injectable, versus the sublingual. Again, Brixadi, it was approved in May, but I think finally approved for release in September. It offers weekly injections and monthly injections. It also offers more injection sites than the Sublocade. So Brixadi, you can give the injection behind the arm, on the back of the arm, the abdomen, above the buttocks, and the thighs, I believe. Yes, the thighs, whereas Sublocade is only in the stomach. So A 6-month review of global treatment satisfaction was conducted, and the depot buprenorphine group reported improved treatment satisfaction compared to the sublingual. One of the things with the depot versus the sublingual, a lot of our patients have difficulty with the hand to mouth. So you would need to work with them about things that they can do to overcome that. A lot of them have done great with the injection, and then some really struggle with not actually taking something every day. So again, the key is just to get a plan together with your patient to decide what's going to be best for them. So methadone maintenance, it decreases or eliminates illicit opioid and heroin use. Again, that is because methadone, your brain has a higher affinity for methadone. So illicit opioids and heroin are not going to give your patient the euphoric feeling of being high while they're taking methadone like it did when they didn't. Reduces the potential to contract HIV, Hep C, and Hep B. Again, that is because they're not using illicitly, they're not shooting up, they're not sharing needles. Decreases criminal activity, they're getting it from the clinic. They're not having to steal or pawn or anything like that in order to get it. Improves maternal and fetal outcomes for women who are pregnant and are breastfeeding. Methadone is safe in pregnancy, is also safe in breastfeeding. Methadone is considered the gold standard for pregnant women. Because it is a full agonist, it tends to help with cravings that pregnant women experience throughout their pregnancy. So there was a large study done with methadone in pregnant women. I believe they called it the Mother Study. Showed how beneficial it was for pregnant women on methadone, how they had better maternal fetal outcomes. And again, that's what the ultimate goal is: healthy mom, healthy baby. So, and then increases treatment retention. Again, you're not feeling you're not feeling bad, you're not having withdrawals, you're not having cravings. So it allows you to focus more on staying in treatment. So they're able to focus more on that than on how bad they feel or their cravings or anything like that. So, and specifically in the justice-involved populations, there's a lower likelihood of opioid or cocaine-positive urine tests. So there's a lower likelihood that they're going to be using any kind of illicit substance, which is going to get them in trouble, or possibly sent back to jail or anything like that, which we do not want. There's a higher mean number of days in community-based substance use disorder treatment upon release from prison, an increased rate of retention and treatment programming. Again, if you're feeling okay, you're not having cravings, you're not having withdrawals, of course I'm going to be able to focus on treatment. Decrease in crime and illicit drug use because I'm not having to steal and pawn in order to get it. Decrease in infectious disease because I'm not having to share needles with anybody in order to get high. So I don't have to worry about that. Then methadone effectiveness, when dosages are appropriate. It increases the amount of time in treatment, prevents relapse on illicit opiates, decreases crime rates. And then evidence suggests that methadone is more effective than a short taper or medication-free treatment followed by abstinence. Abstinence, we try to encourage our patients and tell them that abstinence is not a realistic not necessarily goal, but it's not realistic, especially for our OUD patients, because of the huge percentage risk of relapse or return to their use, which is not, we definitely don't want them to do that. So we try to encourage them to at least stay on medication for a minimum of a year. And then if they want to work towards, abstinence, then, they do that with sponsor, trusted friends, in recovery, counselor, doctor. It's not, make sure that they know it's not a decision that they make on their own. So, disadvantages of methadone that may produce dependence and tolerance requiring an increased dose over time. Subsequent detox may be more difficult than from heroin, and that's because methadone does store in the bone marrow. So You will have patients on methadone that will have secondary withdrawals, post-acute secondary withdrawals. So you would just need to get a plan together with your patient, if they decide they want to come off the methadone, about, what they're going to do if they start having those withdrawal symptoms, if they want to, switch to buprenorphine, or to naltrexone / Vivitrol, while they, or after they get off the methadone. So, methadone is a full agonist again, at the mu opioid receptor. So therefore it can lead to severe respiratory depression. So you want to make sure to educate your patient if they decide they want to go on methadone, that the biggest thing is that they don't take more than their dose. If they take too much too fast, could lead to an overdose death. And really, under no circumstances should they ever be on any kind of benzo while they're on methadone. Buprenorphine and benzos mixed together increase the risk of an overdose. Methadone and benzos together pretty much guarantee you an overdose. So it's very important that if your patient decides they want to go on methadone, that if they're on any kind of benzos, that they get off of those and switch to something else. So, another disadvantage of methadone, like I said, it's dispensed in special clinics where frequent visits are required. So your patient has to work out how they're going to get to the clinic every day. They do daily dosing in the beginning. So they have to go to the clinic every day to get their dose. They're typically open really early, like 5 o'clock in the morning. So, usually they go after they get off work if they work night shift or before they go to work. So they just have to work that into their schedule. Usually, and depending on the clinic, I think every methadone clinic does it differently. Usually after you've been established for so long and you've had negative drug screens and done your counseling visits, they do start allowing take-home doses. But usually it's a very slow process. And it's not just, here's your 30-day, your 30-day supply of methadone. We'll see you next month. It's usually here's one day. And then usually after so many negative drug screens or so many weeks in the program or however the clinic decides, then they'll give another dose. The most I have ever heard of a patient was 27 take-home doses. And that patient had been in the methadone clinic for 4.5 years to get to that. So it is a long and drawn out process. So it is it's long. Again, you just have to, make a plan, have your patient make a plan, as far as, for the next few years, this is where, you got to work this into your schedule every day, which it can be done. You just got to make sure that your patient realizes all of that. And it's not, it's a long process. So the role of telehealth and overdose, the receipt of OUD-related telehealth services in the pandemic was associated with an increased odd of MOUD retention and lower odd of medically treated overdose. And that's because, during the pandemic, people were afraid to leave their houses. People are afraid. People don't want to go to the doctor because they didn't want to possibly contract COVID. And so making those telehealths available to those patients helped them stay on their MOUD medication. Whereas if they weren't able to continue it, they would have likely went back to their use and probably would have, would have been a potential overdose. So emergency expansion of the telehealth during COVID provided flexibilities for MOUD. And many initiated OUD-related care because of this access. A lot of our patients, especially, at our facility, and a lot of patients that are experiencing addiction also are experiencing homelessness. So, they're experiencing homelessness. They don't have a car to go to the doctor every month to get their prescription. But, they might be able to get access to a telephone to be able to call, or, a computer, or, maybe like a library or something like that to get on a telehealth call. which allows, a telehealth that allows more patients to have access to MOUD that probably would not have been able to previously. So our OUD protocol, we usually begin Suboxone when the COWS assessment is greater than or equal to 13. Typically, it's 24 to 72 hours after the last opiate use, depending on the opiate choice. We do a 5-day taper. We use 2 milligrams twice a day for 2 days, 2 milligrams once a day for 3 days, and then stop. And then the patient, at any point in time during that taper can decide they want to switch to Suboxone maintenance if they want to do that, or they can continue tapering off and switch to naltrexone and or Vivitrol. So we also have as needed meds for symptoms, which include Bentyl, which helps with stomach cramps, Motrin, Zofran, which helps for nausea, Imodium helps with diarrhea, Vistaril and Atarax, which helps with anxiety. Trazodone, which helps with sleep. We actually have switched from trazodone to doxepin because studies have shown that trazodone can give a false positive for fentanyl. So we've steered away from that. That way we know if we're testing our patients that if they're on that they're not on trazodone, then we know if they're positive for fentanyl. It's not because it's not it could be because they're using, not probably because they're on trazodone. And then clonidine for their just the overall feeling of feeling bad. So they're more likely to leave AMA, relapse, and overdose if they're not on some form of medication. And the goal is to meet them where they are. So you want to present them the 3 options and allow them to choose the one that works for them and their discharge plan. For us, if they refuse, we must document the declination. You should also do that. And MOUD is the standard of care. So the patient must be offered and placed on MOUD, or they must refuse it prior to discharging if they're in an inpatient facility. So that's our response. If there's an OUD emergency, we have talked about the opioid antagonist. This is for Narcan. It can be used injected or used nasally. It usually wears off in 20 to 90 minutes. If you've ever had to Narcan anyone, you know that it tends to wear off. So this is a slide of showing naloxone reversing an overdose, how it works. This is an example of reversal agents, Narcan. I don't think the Evzio is in production anymore. It was an auto injector. That would have been a good choice. OpV is another option for Narcan. The big difference is that it costs, it's like double the cost of naloxone. So it's also available over the counter. But again, you'll be paying double for it. So they're working on currently a wearable device like an insulin pump or implant that based on your breathing can inject naloxone. It's obviously not FDA approved yet. So that could be on the horizon. And again, Brett talked earlier about possible vaccines. So phase 1 clinical trials of a possible fentanyl vaccine are supposed to begin in the second quarter of 2025. GLP-1s, which are your Ozempic and Wegovy, those can also, or they're looking at those also being able to treat addiction. And that's because of people that are on them, if you've had conversations with them, they've told you that, it helps quiet their brain from having cravings for food. So they're thinking that it may work the same with addiction. The big thing is that the side effect with all of those medications is a lot of nausea and vomiting, so it's not ideal. So naloxone is unlikely to be enough. Basically, we want to decrease stigma and greatly increase access to MAT. So that is all I got. Sorry I took so long.
No, it's perfect, Jen. Thank you. Appreciate you. Appreciate Brett. I'll invite Brett if you'd like to turn your camera on and join us back. We'll have a couple minutes for some Q&A. I think we've done a pretty good job about addressing a lot of questions as they've come up. If you look at the chat function as well as the Q&A box, you'll see that a number of questions have already been answered by myself, Sherry Schaefer, who's helping us out, as well as Brett. A couple things that I wanted to bring some attention to, and especially because it was talked about multiple times. Pregnancy and MOUD. You know, we've talked about methadone being, you know, traditionally the gold standard here. Other alternatives such as Subutex. Can you speak to any other considerations that go into the utilization of MOUD with a pregnant population that we need to be aware of?
Yeah, so it's also patient choice, obviously. There have been small studies done with naltrexone in pregnant women that were shown promising, but most doctors are hesitant to prescribe it for obvious reasons because it hasn't been studied enough in pregnancy. Really, it's just patient choice. So methadone is considered the gold standard because it's been studied the longest. Buprenorphine, the mono product alone, just buprenorphine, is considered like the second option, which I just saw there was a study posted or published in the Journal of Addiction Medicine, I think in the last week or so, where they've done another study showing buprenorphine or buprenorphine naloxone that they're considering begin to consider that safe in pregnancy as well. So
Very interesting. Thank you. Couple people were asking questions throughout about medication options with methamphetamine. I'll give you what I've been able to learn about this for the last little while. We do not have a medication like we've been talking about for opioid use disorder, for stimulant use disorder. However, there are some studies that indicate utilization of naltrexone, Vivitrol, combined with Wellbutrin, which is an antidepressant medication, that shows some assistance with cravings. Now, this would, for this point, be an off-label utilization of that medication, but the science is pushing us in directions to be in the new frontier here. And like the last slides that Jen was showing, I mean, auto injectors, potential vaccines, and a lot of things we've learned with new medications that come on the market, such as what we've learned with the COVID vaccine and what we've learned with these like Ozempic products that Brett was speaking about briefly. We're learning so much about the mechanisms behind this that it's unlikely that we will not have more solutions in the near future.
And
Brett,
Zach, to
yeah.
chime in on that, there's actually a company out in, I want to say Arizona. I'd have to double check that. There's a company that's actually working on a medication for methamphetamine use disorder now. It's in preclinical trials right now, so I don't even know if anything's been published on it yet. I just happen to have a friend that works with the company that was telling me about it the other day. So there is one in development. It's just got to see what kind of safety issues come up with it, or if any, and what kind of efficacy it'll have. But so far, they've had some really promising results.
Excellent. Thanks, Fran. Hey, since I got you, I've noticed something whenever I'm working with patients with opiate use disorder, their tolerance for being able to manage pain seems severely impaired because of their use, to the point where, you know, after they start entering into recovery, any amount of pain seems to be intolerable to them. You know, we're trying to normalize this experience and talking through it. What's going on biochemically about pain and how it works that's impacting them early in recovery?
So really, it kind of goes back to what I was talking about in the slide. You're overriding your body's natural response to pain. So what your body is doing is it's creating new pathways to receive that pain. And when you remove the opiate or whatever they've been taking that's been overriding that system, not only do they have that system in effect, they have all these new pathways that their brain has created to try to deal with it. And so they have what's called opioid-induced hyperalgesia, I think is what it's called, but it's just like you said, they have an overreaction to pain, whereas, something to them that normally may not even cause a reaction, they'll have just this hyper reaction to it.
Yeah, and that can create so many challenges because, dealing with pain just in life, everybody's dealing with pain to a degree, and it's a major source of triggers for this population in particular. I thank you, Brett. I thank you, Jen, for your input. I'm noting the time. We are sadly out of time for this session. I want to alert to a couple more things. In the chat box, you'll see an ability to grab the survey link if you want to go ahead and pull it now. Some of our colleagues keep reposting them so you can get it. If you happen to miss that link, don't worry. We're going to send you an email very, very soon. In that email, you're going to have a link to do that survey. I encourage you to do it as soon as you can. If you do not get a CE certificate email from us in the next 2 weeks, let us know. Send the email through how you registered, and we will work to correct that. In order to get a CE certificate, though, you've got to do the evaluation. And that's why we're big on pushing to get it done as soon as possible. Get it done, get it out of your mind, move into your weekend. You don't have to worry about it. Connecting with Bradford, we have the information here on the screen. We do have a 24-hour crisis hotline for you. Client you are serving, family member, whoever it is, you can reach us to get some direction on getting into treatment. Also, check out our website. As we've talked about, there's a lot of resources there about the programs that we offer, our locations, as well as future continuing education opportunities. Thank you very much for joining us for this quarter training. We will plan to see you again in December with a new topic that we are baking right now. Talk to you all very soon. Have a good weekend. Bye-bye.
Thank you.